Can we start, Aditya?
We are live now.
Yes. Am I audible?
Yes, ma'am.
Very warm welcome to all the esteemed faculty members and the delegates who have joined today for the 27th episode of the Public Awareness Committee webinar series. Today we are focusing on the theme of contraception. 1st July is the Contraception Awareness Month and 11th of July was the World Population Awareness Day. So this time our theme is contraception and we have a stalwart from the South Coast on the topic. We have Dr. Bharti Rashekar Madam who is speaking on electrical contraception and Dr. Niharika Madam who is speaking about hormone sterilization techniques. Then we have a panel discussion by Dr. Shobha Bhuti Madam. Dr. Aruna Kumar Madam will try and join if possible, but Madam will be moderating the panel discussion on post-abortion and postpartum care. We are very, very thankful to all our Fogsi office bearers, Dr. Jaydeep sir, Dr. Madhavi Patel Madam, Dr. Ajay Mandi sir, Mr. Kalyan sir, and our chairperson, Dr. Priyankur, who under whose leadership we are organizing this webinar. Dr. Shamala Madam will join back around at 5:30 so we can take her lessons after Bharti Madam's lecture. I take privilege in introducing our chairperson for the first session. Abhishek, can we have the slide, please?
Ma'am, your voice is not clear.
Can we have the slide, please?
Of what, ma'am? For prayer?
Of this.
You can start, Abhishek. Start the program with the prayer.
With the blessings of Lord Almighty, can I start the webinar, ma'am, with your permission, Bharti Madam, as the convener of this program?
Monica, your voice is not very clear.
Hello.
I think remove your earphones and speak directly.
Am I audible now?
Yeah, now you're
Yes,
fine.
ma'am. Clear.
You're fine.
Yes, ma'am. Ma'am, can we start with the webinar with your permission as the convener for the program?
Yeah,
Yes.
of course. Please go ahead. Please go ahead.
Can we have the chairperson CV, please?
Abhishek got disconnected.
Our chairpersons for the first session, Dr. Rajlakshmi Madam and Dr. Shailija Madam. The next slide. Here. Dr. Rajlakshmi Madam has been a consultant obstetrician and gynecologist at the Vatsalya Clinic at Sanketi, Udupi. She is the alumni of Kasturba Medical College, Mangalore. Her areas of interest include adolescent health, infertility, and public awareness, and she has been a faculty at state and national conferences. She is also the master trainer of Fogsi Dhira, No to Violence Against Women. She has been actively involved in all public health awareness activities, including print media and TV. We welcome you, ma'am. Our next person is Dr. Shailija Akula, madam. She is running a 25-bedded hospital at Minkumalta, Karimnagar. She's been practicing since 20 years and she has conducted more than 25,000 surgeries so far. We welcome you, ma'am. And we welcome Rajlakshmi Madam as chairpersons for this session. And I request you to please introduce our speaker, Dr. Bharti Madam, today.
Thank you, Dr. Monica, ma'am. It's my pleasure to introduce Dr. Bharti Rashekar, ma'am, President of Karnataka State OG Society. She's been the KPMA State Vice President, Director of Indian Red Cross Hassan, and HSOG past President and Secretary. She has lots of awards and activities. She has won the President Medal for being topper in final MBBS. Fogsi President, rotating trophy as Secretary of SHOG. Faculty in various national and state conferences, actively involved in adolescent health programs, conducts first aid and basic life support workshops for public drivers colleges. President rotating trophy as President of HSOG. She is the recipient of Rajyotsava Award for work in healthcare and Hassan.
Yeah, thank you, Dr. Rajlakshmi.
Yeah, it's a pleasure to welcome you, ma'am. She will
Thank
speak
you.
on implantational contraceptions. Over to you, ma'am.
Injectables. Yeah. Thank you, Dr. Rajlakshmi. And it is indeed an honor to have you from my very own state and Dr. Shailaja from Karimnagar chairing the session. And I thank the Public Awareness Committee Chair, Dr. Priyankur, and the conveners, Dr. Monica and Satabdi, for giving me the opportunity. And of course, contraception is what is something that we, in spite of we talking and propagating and the government of India taking it up on a larger protocol, we still have a lot of unmet needs, and this has to be addressed by each and every one of us day in and day out. So I will be sharing my slide. I hope it's visible.
Yes.
Yeah. Fine. So I will be talking on injectable contraceptives because implants was one of the choice, but I thought I will go for injectables because that is something which is more feasible for our population and more acceptable at the present moment because of the limited availability of the implants in all quarters of India. So I bring greetings from the Hassan Society of Obstetrics and Gynecology. So, what is the impact of contraception? Over the years, India's National Family Planning Program, which was, one of the first which was introduced way back in the 1970s, has been a very effective program, but it has evolved with a shift in focus from merely population control to more critical issues of saving the lives and improving the health of mothers and children through using of the reversible spacing methods, which lead to reduction in unwanted births, closely spaced births, and mistimed pregnancies, and thus avoiding pregnancies with higher risks and chances of unsafe abortions. So the impact of contraception is so high that without contraceptive use, the number of maternal deaths would have been 1.8 times higher than at present. So contraceptive usage has averted 44.3% of maternal deaths worldwide. It can avert more than 30% of maternal deaths in our country and 10% of child death if couples space their pregnancy for more than 2 years apart. And the UNFPA study has estimated that if the current unmet need for family planning could be fulfilled within the next 5 years, the country can avert 35,000 maternal deaths and 12 lakh infant deaths in our country. So that is the impact of the unmet need we are having now. So in the present scenario, we have various options are limited, but they are mainly limited to condoms, IUCDs, and oral contraceptives, like 5.9% in condoms, 1.9% in IUCDs, and 4.2% in the oral contraceptives, excluding the surgical methods of contraception. There has been a mix of these family planning methods, and there has been a linear increase in the contraceptive use rate by about 3 to 4%, but that is not sufficient. It is therefore imperative to increase the basket of choices as well as service coverage in the National Family Health Program. And that way, the Family Health Program in the India has now added more drugs into the basket, which we have the injectable contraception as well as the implants which have come into the National Contraceptive Basket. Today, my talk will be only on types, the injectable contraception that is now recognized and available in the Family Planning Program of India. So we do have injectable contraceptions which are only progesterone containing injectables. That is the very familiar depomedroxyprogesterone acetate, or the Antara, which is available in the National Health Program, which we are using routinely. And of course, the other injectable which is available in the market is norethistyrone enanthe, which was used earlier, but I think we do not use it nowadays much. It's a 2-monthly injection. And there have been studies of having combined injectable contraceptives which use ethinyl estradiol and progesterone, like the OC pills. It is a 1-monthly injection that is, it does away with the regular intake of the OC pills, but this is not available in the Indian market, nor is it there in our family planning basket. So what is a global and national use? So now from this slide, my talk will be only on the use of depomedroxyprogesterone acetate, which is the most widely used injectable progesterone. So it is the most prevalently used, and estimated 42 million women worldwide are using it. However, you see in Indonesia and Bhutan, the usage is around 31%, coming up to 14.8. And as we move towards this Indian subcontinent of India, we see in Thailand it is 11, in Bangladesh it is 11.2, 9.2 in Nepal, and a dismal 0.1% in 2013 Population Reference Bureau. In India, it was just as low as 0.1%. DMPA has approved, the DGCA has approved this in 1993 as an injectable contraceptive method. In 1999, social marketing for DMPA continued, and overall, the contraceptive use of DMPA still remains small. So the NFHS 2005-2006 showed us that it is only 0.1%. It has increased from 0.004% to just 0.1%. That is the dismal usage of DMPA, in spite of it being an excellent drug in the management of population stabilization. So what is DMPA? DMPA is depomedroxyprogesterone acetate, a synthetic progesterone which was developed in 1954 by the Upjohn Company for the treatment of endometriosis and habitual or threatened abortions. But in the early 1960s, they noted that those women who used DMPA for premature labor had a marked delay in return of fertility. This observation led to the development of DPMA as a fertility regulating agent. So as early as the mid-1960s, Upjohn got a contraceptive product license for marketing DMPA as a contraceptive in many countries. And since then, it has become quite popular. And of course, it was available in the Indian market. We were using it, but it just recently, it has come into the national protocol of contraception. So what does it contain? DMPA is an aqueous suspension of microcrystals for depot injection of pregnane 17-alpha hydroxyprogesterone, which is a derivative of medroxyprogesterone acetate. So it is, I will talk to you about how it is given and when it is given later on. So what is the mechanism of action of DMPA? It acts by a three-pronged attack of inhibiting, thickening, and thinning. It inhibits the ovulation by suppressing the mid-cycle peak of LH and FSH because it is a progesterone compound. Hence, it is also useful in endometriosis and abnormal uterine bleeding. It causes a thickening of the cervical mucus due to the depletion of estrogen, and the thick mucus prevents sperm penetration into the upper reproductive tract. And thirdly, it causes a thinning of the endometrial lining because it's a high progesterone and a low estrogen endometrium, making it unfavorable for implantation of the fertilized ovum. So this injectable contraceptive contains the synthetic hormone resembling the natural female hormones, and when administered either intramuscularly or subcutaneously, there is a slow release of the hormone into the bloodstream, and this provides protection from pregnancy for a longer duration of time for the client. So the route of injection is generally right now what we use is the intramuscular DMPA. Intramuscularly, there are few preparations which can be used subcutaneously and are now available in the market, and they can also be self-administered by the client, just like they take their injections for IVF or other subcutaneous insulin or whatever they're taking. So that is again new on the market. So this DMPA, which is an intramuscular DMPA, is a single dose vial with a disposable syringe. It is pre-filled. Whereas the subcutaneous DMPA also comes in a pre-filled auto-disable syringe in the Uniject system. That is, you just squeeze it. There's nothing to draw and then inject. Whereas in the DMPA, you will have to draw it. So it does have contraceptive benefits as well as non-contraceptive benefits. So it is safe and highly effective with long-term contraceptive benefits. It's convenient and easy to use that does not require daily routine supplies. It acts for 3 months with a grace period of 4 weeks. It is completely reversible 7 to 10 months from the date of last injection. Average, it will take about 4 to 6 months for regular ovulation to start following the last injection. It's a very private and confidential method. She can even take, if she has a subcutaneous DMPA, she can take it in her home, in her own privacy. It does not interfere with sexual intercourse or pleasure. It is suitable for women who are not eligible for an estrogen containing contraceptive, like if they have thrombosis, VTE, obesity, such individuals. It is safe for them. It is suitable for breastfeeding women, provides immediate postpartum and post-abortion contraception, and it can be used at any age or parity, excluding some factors which are available, I will come to later. So coming to the safety, it exerts a strong protective effect against endometrial cancer and also used in endometriosis. There is no overall increased risk of breast, ovarian, and cervical cancer in women using DMPA. The risk is same as those women using other methods of contraception. It does not affect the risk of developing liver cancers in areas where hepatitis B is endemic. It does not cause any significant changes in blood pressure or the coagulation pathway, keeps the fertility intact, though it takes a few months to reinstate the ovulation. It is highly effective contraceptive method, as I told you, effective in almost 99.7% when the drug is used correctly. The injections are taken as per schedule. The failure rate is just 0.3%, lower in comparison to 0.5% of female sterilization, 0.8% of IUCD, and 0.3% on par with combined OC pills. And of course, the effectiveness depends on the time they take the injection and the regularity in which they take the injection. That decides the effectiveness. The timing of the first injection, taking injections regularly, the injection technique very much matters for the effectiveness, and post-injection care, which I will be elaborating. Along with this contraceptive benefits, it does have non-contraceptive benefits, like it reduces abnormal uterine bleeding. This is correction of anemia, and PMS symptoms are sometimes addressed. Vasomotor symptoms can be addressed with these. Perimenopausal symptoms can be addressed with DMPA. However, it does have certain limitations. What are the limitations? It does not protect against STIs and RTIs and HIV infections. So in such high-risk groups, an additional barrier, not as a contraception, a barrier for safe practices can be advised. Once action has been taken, it cannot be stopped. So once you take an injection, 3 months, she will not ovulate. So the effect, her coming back to ovulatory status may take some time. It can cause changes in the menstrual cycle and bleeding, which is one of the most important reasons for women giving up this technique. It has to be repeated regularly every 3 months to achieve desired contraceptive effects, but I don't think that's a limitation. Return of fertility takes average about 4 to 6 months. I think in women, if we explain and the couple can counsel, it is not an issue. And it cannot be given in few medical conditions, which I will elaborate later on. So what are the eligibility criteria for DMPA? We know that all of us, when we prescribe contraception, please do make use of the WHO medical eligibility criteria wheel. And depending on that, you can choose the contraceptive of choice, present the choice to the couple, and let them make the choice from the basket of contraceptive methods available to us. Eligibility criteria, any age, including adolescents and women over 45-year-olds, I will talk to you about adolescents later on, can use DMPA. Whether they are nulliparous or multiparous, they can have it. Unmarried girls who are sexually active can take DMPA. If they have just had an abortion or a miscarriage, it can be started immediately. Smokers, and regardless of age, they can take, because there is no risk factors involved in this, like in the estrogen containing pills. And breastfeeding, you can start soon after 6 weeks after childbirth. This contraception can be started. And of course, if they're at a risk of STI and HIV infection, you need to explain to them that you have to have safe sex. And even if they are infected with HIV and they are on or not on antiretroviral therapy, you can safely use the injectable progesterone only injectable DMPA, and all you have to do is use the medical eligibility wheel, and depending on that, rule out the risk factors and very safely prescribe the injectable contraceptive to these women. What about breastfeeding women? In special circumstances, how do you prescribe? Well, if breastfeeding woman, she's completely feeding, total breastfeeding for the child, wait until 6 weeks postpartum and then start DMPA. It can be started at any time between 6 weeks and 6 months if she is fully or near fully breastfeeding and her monthly bleeding has not returned. There is no need for a backup method. However, if she is not breastfeeding or she's partially breastfeeding, you can again start at any time. There is no need for a backup period, but be certain that the woman is not pregnant. So how do you know that? One is by history. The second thing is you can confirm it by history of whether she's had any sexual contact. And the second thing is if she has come in the first week of her menstrual period, or if she can get a urine pregnancy test in case she is having irregular cycles. She will need a backup, either a condom for the first 7 days after the injection when she is not breastfeeding. And if her monthly bleeding has returned, she can start injectable as advised for women having menstrual cycles, that is within the first 7 days of the menstrual cycle. So if she's not had her menstrual cycles and she's feeding, you can start immediately. But if she has started her menstrual cycles, I think you'll have to rule out pregnancy before you give her. So in special situations, as I told you, when a woman is having menstrual cycles or she's switching from one method to another, please start any day within 7 days of the menstrual cycle with no need for a backup. It can also be started at any time later in the menstrual cycle, but be certain to rule out that she is not pregnant. 1. 2, she will need a backup method for the first 7 days after the injection. However, if she is already just switching from an IUCD, it can be started immediately. If starting after 7 days of the menstrual cycle, she again needs a backup method. You're switching from a hormonal method like an OC pill can be started immediately if she has stopped the drug and if it is reasonably certain that she is not pregnant. So no need to wait for her next monthly bleeding, and there is no need for a backup method. There are, as I told you, breastfeeding, I already have elaborated on that. If she is completely breastfeeding, after 6 weeks, you can start the drug. If she is more than 6 weeks, 6 months postpartum, and she has had her menstrual bleeding, start within the first 7 days. If she has not had her menstrual bleeding, try to rule out a pregnancy and then give her the injection. And not breastfeeding, as for if she has had her menstruation, you can give it the first 7 days. If she has not had menstruation, rule out pregnancy. What do you do after a miscarriage or an abortion? It can be started immediately after an abortion, especially when these girls, young girls, come to us after MTP, they're sexually active. They generally do not come back to us for contraceptive advice in spite of counseling. So this is a good opportunity to just give them a prick and send them so that the next 3 months, even if they miss coming to the physician for a contraceptive advice, she will at least not get pregnant. So it can be started immediately or within 7 days of the first or second trimester abortions with no need for a backup method. When do we not prescribe DMPA? When the woman is breastfeeding and she's less than 6 weeks postpartum, please wait. If her blood pressure is 160 and 100 and more, you would rather control her hypertension and choose another alternate method like an IUCD. And once the blood pressure is controlled and she has no risk factors for venous thromboembolism, you can definitely, though DMPA does not carry a risk of venous thromboembolism, get her blood pressure controlled and then you can prescribe. Unexplained vaginal bleeding, you have to rule out the cause for unexplained vaginal bleeding, whether she has a polyp, she has a malignancy, or she has any other issues, and treat them for that. Do not prescribe if the vaginal bleeding diagnosis has not been made. According to the category 4 as per WHO MEC, do not use them. So, coming to the success of this program, this counseling is very, very important. I think where we are lacking in this reduced uptake of this DMPA by our own clinicians as well as the clients, I think is because we ourselves are not confident of what counseling we are doing. The second thing is we are not spending enough time with the healthcare workers, the paramedics, the ASHA workers, and telling them that they have to spend time counseling. So the benefits you have to tell them in counseling, because once you do the proper counseling, there will be increased acceptance. It enhances the continuation of the methods. It dispels the myths and rumors, promotes effective use, and increases client satisfaction. And what should be the principles? Give them privacy, confidentiality, be respectful, non-judgmental, accepting and caring, use simple vernacular language, small words, and try to be simple and give them the chance to answer questions. Use visual aids and models. Repeat the key information to find out whether they have been well informed about it, and then make them make the choice voluntarily. We do not make the choice for them. Let us give them the opportunity to understand and then make the choice. Once they've made the choice, we will have to assess the clients. So whether they have had any history of venous thromboembolism, any history of cancers, any history of jaundice, any history of diabetes, hypertension, abnormal bleeding, and whether they are less than 6 weeks postpartum. So you assess all these on the checklist. The Government of India guidelines on injectable contraceptives, everything is given within the annexures. We have all the charts, all the checklists, everything is there. Most of my presentation comes from there. So you could download that and give it to your paramedic staff who are doing the counseling so that they can give them effective counseling and then pre-checkup and post-checkup. So now once we have counseled them and they have taken the choice of an injectable contraceptive, if we have given them proper counseling, how do we prepare? So we have counseled them and they have chosen DMPA. Check the vial for the expiry date. Shake the vial well. Very important for effectiveness of the contraceptive effect. If the vial is cold, warm to body temperature by rubbing between, because it is a crystalloid injection. Ensure that all the microcrystals are dissolved in the fluid. Wash hands for the usual universal precautions. Withdraw the full quantity of solution from the vial into the disposable syringe with the needle, taking care not to push any outside air into the vial. What are the common sites of the injection? Commonly, it has to be a deep intramuscular injection if you're using the intramuscular vial. So in the deltoid region or gluteal region, I generally do not use, because most of our women have a lot of gluteal fat. And we land up injecting that oil injection into the fat. They land up, one, with an abscess and pain. The second thing, there is less effectiveness because the drug does not get absorbed properly, and that causes problems. The outer side of the thigh is a very, very useful location for the injection of the DMPA. So I would choose either the outer side of the thigh or the deltoid region. Of course, the gluteal region, if we could identify the muscles. In obese women, try to avoid the gluteal region. So injection, as I said, clean, then insert the sterile needle deep into the chosen site, aspirate to ensure that the needle is not in a vein, and inject the contents of the syringe full. This next thing, what I'm going to tell you, post-injection care. Do not massage the injection site. All our nurses have this habit of rubbing the injection, or the woman, the lady herself wants to rub the injection, or her mother is standing there and trying. Do not allow them to massage the injection. Why? This massaging the injection site interferes with the absorption of the drug. There may be rapid absorption and it may not be effective for the 3 months as it should be. If there is little oozing, just apply pressure for a few seconds. Ask the client to remain within the facility for 5 to 10 minutes and then leave the facility, and follow safe practices of disposing your syringes. So post-port, I told you, no massage or no hot fomentations to the injection site. Needs to be repeated every 3 months. Explain that menstrual changes are common. Tell her she can return at any time, especially if she has concerns or problems, and always give her a helpline so that she can come to the concerned person and express her difficulties. Well, this is one thing which is being detrimental in preventing the uptake of our DMPA. The various myths, not only about DMPA, I would say even about OC pills and IUCDs. So, will irregular bleeding mean something harmful has happened to me? Will stoppage of period lead to infertility? Will stoppage mean that I have a failed pregnancy? I am pregnant. Will stoppage mean my eyesight will be weak? And stoppage of period means I'm attaining menopause, and there's collection of dirty blood in my body. So there are various myths. So how do we eradicate these myths? It is just by counseling, explaining to them what is menstruation, where is this blood coming, and why is DMPA not giving her a regular menstrual cycle in those individuals who are not having a regular menstrual cycle. We have to spend time and counsel them. So there are a few dropouts who will come late. So if she comes more than 4 months from the last date of injection, rule out pregnancy first. If not pregnant, you can give her the DMPA injection, ask her to come back in 3 months and give her a reminder call, ask her to keep an alarm. There are apps where she can set an alarm. And ask her for the reason for coming late. And if she's having a problem coming, you can discuss other methods of family planning. Well, nothing is without side effects, I would say. One of the most common side effects are menstrual irregularities. There may be a marginal weight gain, but I would say weight gain may be more due to the lethargy and the unhealthy food habits of that individual. So we can eliminate that by asking her to do lifestyle modifications. Some women, especially those with little migraine, may have headache. That is because of the progesterone and the fluid retention. And I think for that, you can either prescribe an analgesic or an NSAID and give her some yoga meditation and explain and counsel to her. She should be okay with that. Mood changes may be there in the initial stages, and sometimes sexual disturbances, probably because she's not having her periods. An estrogen effect is not there. There may be a little dryness of the vagina, for which you can give her lubricants. Menstrual irregularities, I'll be talking to you. This is what is most commonly they come to us. We have to counsel and reassure her pre-injection, post-injection, and also during the follow-up assess to allay the client's anxiety. Assess the bleeding change when she comes to us. Don't just say it'll happen with DMPA, go home. Do an examination. Rule out whether there is any other problem for her abnormal uterine bleeding. Does she have a polyp? Does she have any other issues? Rule out gynecological causes. Don't be cursory about it. Manage the menstrual changes as described. So if the next injection is due and she's having, you can always prepone the injection. Instead of like she's come to you in 4 or 5 weeks with irregular menstruation, the 12th week dose can be given at that time. But if she does not want to continue the method, you can help her choose the other method. So if she has irregular bleeding, you can reassure. For modest relief, you can give her NSAIDs like ibuprofen 3 times a day, mefenamic acid, tranexamic acid, 500 milligrams 3 times a day. If she has heavy bleeding, you can reassure, give her NSAIDs. If she's not responsive, you can always substitute 50 micrograms of ethinyl estradiol or even estradiol 2 milligrams for 21 days. That sets the cycle back. And if she says she's okay with it, you can give her the next dose. If she does not, then you can always change over the method of contraception. In addition to that, if she's bleeding heavily, give her iron supplementation and nutritional advice to prevent iron deficiency anemia. And when they're amenorrheic, this is when they come to us and say, am I pregnant? And they would have got the pregnancy test done 3 times at home. Please tell them that during this 3 months, the chances of pregnancy are very, very rare. And tell them that absence of periods is not harmful, but however, rule out pregnancy, reassure her, tell her that it is common and not harmful. No medical treatment is necessary to induce withdrawal bleeding. There is no need for a woman to menstruate every month. Menstruating even 3 to 4 times a year is sufficient. It will not interfere with her. It is just like how she's amenorrheic during lactation or pregnancy. There is no bad blood building up inside her, and it does not mean she's infertile. So try to eliminate all these myths with her. But if she's still not happy with it, you can always help her choose another method. And menstruation usually resumes after discontinuation of DMPA. But one concern we have is long-term use of DMPA. Does it affect the bones? It does cause a decrease in bone mineral density by 5 to 6% in 5 years of usage, most of it happening in the first years. Hence, try to avoid using DMPA in younger children and adolescents because it may cause a little decrease in their bone mineral density. Why? Because there is interference with production of estradiol, but however, it is reversible. There is no increase in fractures, and a routine BMD testing is not recommended. But however, you could, if she is lactating, you already supplemented her with calcium, supplement them with calcium, vitamin D, and ask them lifestyle modification to do resistant exercises and a routine exercise of 45 to 55 minutes so that their bones are strong and their muscles are also strengthened. So what happens in case there is exposure to the fetus in utero? There's a rare event of a medical failure or a woman conceiving shortly after discontinuing DMPA or while she's taken it. There is no increased risk of congenital anomalies or effect on growth and development. In case pregnancy occurs during DMPA, she should discontinue the use of DMPA. If she wants to continue with pregnancy, she can definitely go ahead. Otherwise, she could opt for an MTP due to a pregnancy contraceptive failure. So the Fogsi has endorsed all that what I've told you as an effective, safe, reversible method of contraception. The WHO has recommended this from 18 to 45 years of age. There should be no restrictions on the use of DMPA. Among adolescents and women over 45 years, the results of using DMPA generally outweigh the theoretical safety concerns regarding fracture risk. There should be no restriction on the use of DMPA among women who are otherwise eligible to use this method. And in the high-risk group, there is no restrictions. So this is the Fogsi with the RCOG and the WHO guidelines endorsing the use of DMPA, which is safe, effective, accessible, and economic also. So we need to use it in a wider perspective to meet the unmet needs of contraception in our country. And I think Kasoga, along with the Public Awareness Committee, should take this forward so that we can see that it is used in a wider perspective. So these are my references. And I take this opportunity to thank the Fogsi Public Awareness Committee and all the participants here for listening to me patiently. And at the same time, I take this opportunity to request all of you to kindly support my candidature for the Fogsi Perinatology Committee. The elections will be coming up from the August 16th to August 25th. The president and secretaries of all the societies, along with the Fogsi office bearers, will be there to vote for me. I request each one of you to kindly spread the word and support me to do much more as a member of the Fogsi team and also in the Perinatology Committee. And namaste to each of you. And thank you, Dr. Monica, for the opportunity. And thank you, Abhishek, for the platform.
Thank you so much, ma'am. I request the chairpersons to please give concluding remarks, ma'am. Rajlakshmi, ma'am, and Shailja, madam.
It was indeed a very interesting and informative about the injectable contraceptives. My small doubt, madam,
Madam.
if in case within 6 weeks of postpartum period, if the injectable is given, is there any side effect within 6 weeks?
Madam, the guidelines as such, with the WHO guidelines and the MEC wheel as we have, they tell us not to give it within the first 6 weeks of mothers who are breastfeeding their children. But with the studies showing that the use of DMPA does not cause any teratogenicity on the fetus in case she becomes pregnant, in case accidentally it has been given, I'm sure it should not be a cause of concern. But according to the guidelines, we are not supposed to give it 6 weeks postpartum.
When we give after 6 weeks also, the mother will be feeding, no, madam?
No, I think it's probably because the progesterone effect, the efficacy of the drug, it is not because of the teratogenicity or the effect on the fetus. It is more because it will interfere with the involution of the uterus because the mother is still in puerperium and the progesterone effect of pregnancy is still there. Maybe the effectiveness of the drug is not there. That is why it is not advised first 6 weeks of postpartum, not because of the effects on the fetus. I mean, effects on the breastfeeding.
Okay, madam. Thank you, madam. It is really informative.
Thank you, Dr. Shailaja.
Thank you.
And
Thank you, ma'am,
Dr.
Dr. Bharti. It was a very comprehensive message on injectable. I have just one doubt, ma'am, before we go. I have been using it very long. Only problem I face is amenorrhea. Usually they don't bleed for 3 to 6 months also. So I want to ask how many doses we can give for a lady? How long we can give the DMPA injections?
Ideally, they say that it is reversible method. It can be continued up to 5 years. But you know the cultural myths that are there, so we have to go by that and we have to modify it. So what I generally do, the first 1.5 years, they are not bothered about their periods. Up to 2 years, they are breastfeeding. They are not bothered about their periods. Once we give them 2 doses, 3 doses, and they are bothered about their periods, I do add an estradiol, and they have their withdrawal bleeding, and then they come back and say we will go back to the same injectable progesterone because they're very happy with it. Many of them are very happy, and their anemia gets corrected, and they're quite happy with continuing the drug.
Thank you,
so up to 2 years, using it up to 2 years without a break, I think is not a problem. That's what I do in my practice.
Okay, ma'am. Thank you, ma'am. I
Thank you.
Dr. Monica and Public Awareness Committee for this opportunity. Over to you, ma'am, Dr. Monica.
Monica, can I
Thank you, ma'am.
Yes, Dr.
Yes,
Shobha is
Mr.
there. From one webinar to the other, she has jumped. I came first, she came second.
I was following you, Bharti,
Yeah.
as I rightly should. I should follow the Kasoga president wherever she goes.
Okay.
So see, Bharti, that question on the Depo-Provera, there is some concern of using this progesterone within 6 weeks because I think in breastfeeding mothers, an early onset of hormones is For non-breastfeeding mothers, this caveat is not there. We can give them earlier. It is only for breastfeeding mothers. It's not because of the harm it may cause. Very small fraction comes into the milk. It is because it may have some suppressive effect on the lactation. Because of, this medroxyprogesterone also has mild estrogenic action. So just like we don't give COCs for the first 6 months, though the risk of thromboembolism goes away by 6 weeks, we don't give for 6 months. But because of this only, it may change the nature and the quantity of the breast milk. But after 6 weeks, there is ample time for the lactation to get well established, and external influences will not matter. And that is when we can start the Depo-Provera. So the other question was about amenorrhea. Actually, amenorrhea should not be deterring us. See, this question has been asked many times in forums. See, there are many women who use Depo-Provera for years together. And there are those NGOs, like, for example, FPAI, who give a lot of field service. They say that they are prescribing and providing injectables for 5 years, for 7 years, and nothing happens. There is reversible bone loss. In time, it recovers. No fractures. And also, this amenorrhea is not harmful amenorrhea. And the thing is, what you said about something else you said. How long can we give?
Yeah, how long can they take it?
Yeah, it is possible to give as long as the woman needs. As long as the woman needs. That is what is the current understanding. See, there was some genuine concern about medroxyprogesterone injectable and breast cancer, but it was found to be ill-founded. There is no risk of that. So one thing good is that it provides delay in return of fertility for 8 to 10 months. So if you want a spacing of 4 years or 3 years, you can give about 6 injections and she is protected for 3 years. It is something like that. So it is a good method. We often say that injectables are a woman's best friend and LNG IUS is a gynecologist's best friend. It goes like that. So it's very confidential. She can just go and take an injection, and today subcutaneous is available. She can buy and take it in her bathroom. There is no problem. Okay.
Thank you, Dr. Shobha, the expert on contraception, for those valuable inputs.
Yeah, thank you.
Thank you, Chairperson.
Thank you, Bharti.
Am I audible? Can I request Sharmila Madam to please give us a few words of blessings as Madam has joined back?
I'm so sorry I left in the middle. But I am also jumping from webinar to webinar. Suddenly, everybody wants the webinar on Thursday. I can't understand the logic there. I'm extremely thankful and happy to join a webinar of Public Awareness Committee. All friends there, Monica, Sadapti, Priyankur. And it's wonderful that you have taken all the South societies, Monica, and wonderful speakers. We heard Dr. Bharati talk, a very, very lucid, clear talk on injectable contraception. And I think the next will be by Niharika, who's also a very, very a person who has so much of clarity, and she was the editor of a book for South Zone Conference, and she did it so well. I have to thank Niharika in this forum, and Shobha Madam and Dr. Aruna for the panel. And when Shobha Madam is there, I don't think anybody should have any doubts on contraception. Madam will clear in every point. And I had somebody ask, like, Madam talks only on contraception. I said, no, she's an expert obstetrician also. Should call her for obstetric talks also. Because you have so much of clarity in your thoughts and a wonderful list of panelists. And I'm seeing Sarana Kumar, I think Subhash has joined, and so many wonderful people, speakers. Thank you so much, Monica, and all the best for the webinar. And you should go for elections. You're doing so many webinars even now.
No, I only do
webinars. She is the next in lines.
Yeah.
No.
Thank you so much for the opportunity. A wonderful webinar. I heard Bharati talk, and I'm just waiting for Niharika to start a talk. Thank you so much for the opportunity. Thank you.
Thank you, ma'am. Thank you so much for gracing the occasion and your words of blessings and being the backbone for the Public Awareness Committee as always. I think Dr. Subhash Mandya sir has also joined us. So can we also have your words of wisdom, please?
Subhash must be operating.
He was visible, ma'am. He was operating, but he was
He
visible.
is taking, he is just making us happy with his photograph.
You can go on to the
No,
talk.
he's there.
He's come. He must have heard us make fun of him.
No. He hasn't come. Dr. Raghavendra has come.
No, sir, I've seen.
Raghavendra
No,
finished operating and came.
no, Subhash's audio came, video came. That's why I'm sorry, that thing went off, audio thing. So probably he joined it. Yeah. Thank you so much.
Madam, really sorry, ma'am. I'm really sorry.
I told you. The mummy came.
Really sorry that I could at least I heard some part of the talk from Bharti ma'am. Ma'am, again I wish the public awareness community all the very best, and I'm very happy to see my friend Raghavendra sir also here and Dr. Bharti. And I wish, Monica, we'll soon have a webinar for you also, requesting you to vote for you in the near future.
Yes.
We're all looking forward for that. And I'm happy to see Dr. Niharika, Dr. Shobha madam, and everybody. Hi, Dr. Rani. Hi, ma'am. Right. Charmila ma'am, I'm extremely sorry I couldn't join you in your program.
No, I'm keeping that in my mind. It's in my mind.
I know, ma'am.
Yeah, you better keep it, Charmila. Better keep it.
Yeah, I'm keeping it.
No, Charmila. He has the Google outage as an excuse now. He has the Google outage.
There was some VVIP and which I couldn't avoid, but that is why I had told them also. I called up and told the boys to give me presentation also.
So I'm not a VIP for you.
Don't hang around too much. Don't hang around with too many VIPs.
Many speak Tamil here. Bharati understands totally.
VIP syndrome vandro. Nariya VIP பின்னாடி போகாத.
என்ன பண்றது மேடம், ஒருத்தர் வந்தாரு, அதனால ரொம்ப கஷ்டமா போச்சு.
Become a soft target, Subhash. You get on with your talk now.
Yes, please go on.
Okay, ma'am. Thank you, ma'am. Thank you very much for the honor, and I sincerely apologize because the case got a bit delayed. Sorry for that. Thank you, ma'am. Thanks a lot. Thanks.
Thank you, Subhash sir, for joining us, and thank you, Charmila ma'am, for joining us for the inauguration.
6.5. 6.5 very close. Edutala.
So the next,
Mute him.
We move forward to the next talk by Dr. Niharika Allu madam, our chairpersons for the session. Dr. Rani Lakshmi madam and Dr. Raghavendra Prasad sir. Dr. Rani Lakshmi madam is an associate professor at Department of OBGYN at GNC Kottayam. She has a fellowship in advanced obstetric ultrasound and fetal echo, and she has been the past secretary of the Kottayam OBGYN Society. Her special interest includes fetal medicine. We welcome you, ma'am. Our next chairperson is Dr. Raghavendra Prasad, who is also the convener and the South Zone coordinator for the Public Awareness Committee. He is the director of Infertility and Feto-Maternal Unit of Sunrise Hospital and an executive director at ARMCF IVF Mangalore. We welcome you, sir, and I request Rani madam to please introduce our speaker. Lakshmi ma'am, are you there?
Sorry, I forgot to unmute. Thank you, Public Awareness Committee of Fogsi, for inviting me for this webinar. And respect to all the senior members over there. And I'm only happy to introduce Dr. Niharika. She's a consultant obstetrician gynecologist at Rainbow Hospitals, Visakhapatnam. She's an associate member of RCOG London. She is the secretary of OGSV at present. She has received the Fogsi Achievers Award 2023. She has even contributed a chapter to ethical and medical legal issues in the perinatal period. And she was a faculty at various national conferences. Okay, and has a field of interest include high-risk obstetrics, minimal access surgery, and urogynecology. Over to you, ma'am. We are happy to listen to you.
Thank you so much, Dr. Rani Lakshmi. And I bring greetings from the city of Destiny, Visakhapatnam. And I would like to thank at the outset the Public Awareness Committee Chairperson, Dr. Priyankur Rao, the conveners, Dr. Bharti Rajshekar, Dr. Raghavendra Prasad, and the coordinators, Dr. Monica and Dr. Satabdi. And also greetings to Dr. Charmila ma'am, Dr. Subhash sir, Shobha Gudi madam, for being a constant inspiration to youngsters like us. So let me just share my screen. Is my screen visible?
Yeah.
Yeah.
Yes.
Right. Yeah. So today I've been asked to talk about permanent sterilization techniques. So as we all know, in India, I think over 4.1 million female sterilization procedures are done annually. And when you look at the statistics, there's a staggering 34% of female sterilization in comparison with only 1% of male sterilization. And all the other methods are much 10 percentile. And we actually have need, as Dr. Bharti was telling me, that we have almost 46.3% non-acceptors of any contraceptive method. So why is it that the sterilization method is the most preferred? It's because it is the safe method, it is highly effective, it is hormone-free, it's a permanent form of contraception, so they don't need to have any ongoing effort on behalf of the patient, and it is effective immediately. So that is why a lot of people prefer this kind of method. So let us look at what is the eligibility criteria. So any women who has been ever married with age between 22 to 49 years will be eligible for getting a tubectomy. And the couple should have at least one child, and the age of that child should be above 1 year when it is sterilization is medically indicated. So preferably we would want to wait. I am working in a corporate setup, and on a regular basis, I don't encourage patients to undergo sterilization because there is a lot of sterilization regret. And being in a unit where I see a lot of pediatric diseases, chronic illnesses amongst children, lot of morbidity and mortality among the children, I always suggest or counsel them for more for the long-acting reversible contraceptive methods. So these are criteria from published by the Government of India in November 2014. And the only indication for tubal sterilization is an informed patient's desire for the procedure to eliminate the future fertility. And an informed patient is someone who should understand the availability, effectiveness, risks, benefits of all the other alternative contraceptive options, and that this sterilization is intended to be a permanent procedure. And the patient's decision should be made by themselves, free from coercion, and forced sterilizations or coerced sterilization procedures are unethical and should not be performed. Sometimes you do hear stories of sterilizations being done without the knowledge of the patient because the doctor deems fit that this patient should not conceive again because it is unhealthy for her medical health or future health, and they do a sterilization without even telling the patient. So none of those things should be done. They are definitely unethical, and none of us should be a part of it. So let us see what is the counseling that should occur before we perform this procedure. So all the women should be told about the availability and effectiveness of the LARC methods. As you can see, when you look at the failure rate of a female sterilization, it is 0.5. And compared to the implants or the IUCDs, it is actually higher. Only the male sterilization is 0.15, and the implant is still lower than that. So the failure rate of an implant is much lower than even the permanent procedures. So I think this is something that you should be able to tell your patients before they opt out for a sterilization procedure. And you need to tell them about the other alternatives like IUCDs. We can put it at different, timeline in their lifetime, and the implants. And I think in the panel, all of this is going to be covered. So I'm not going into detail for this. And you should also, what are the do's and don'ts? When is it, should also know the medical eligibility criteria whenever we are telling them about alternatives, because they would want to know how to go about it and what are the ifs and buts of every alternative method that we suggest. So after we counsel about all of this, if they are still willing to go ahead for a sterilization, then we should take up on that choice. And the next thing is you should also talk about a vasectomy, because it is definitely a safer, less costly, and a period time than a tubal ligation. We all know that the lower acceptance, as you can see very well from the data earlier, that it is comparatively 34:1 ratio of male sterilization because of misperceptions. So I think the onus is on us to educate the patients that male sterilization is a very, very effective method of contraception, permanent contraception. That we need to educate them is that it is not immediately effective and it may take a couple of months for the effect to come. Then another thing that is important that we tell them is about the permanency of the procedure. So a lot of times there is a sterilization regret, and having a sterilization at a young age is the strongest predictor of this regret. And when you look at the statistics, you can see that almost 40% regret their choice if they have done it before the age of 24. But once they are above above 30, the percentage drops drastically to only 6%. Also, I would also want to point out that the recommendation by ACOG is that the clinicians should err on the side of greater patient autonomy. That means even if you think, as I was saying earlier, you should not, eliminate the risk of regret by limiting the patient's autonomy. So if after listening to you counsel all of these things, the patient still wants to go ahead for a sterilization, you should choice and do it for them. The risk of anesthesia and post-sterilization contraceptive failure is also something that we need to talk to them about when we tell them. So there's a cumulative 10-year failure rate of tubal sterilization. When you use a traditional occlusive method to a partial salpingectomy, it can range anywhere between 7.5 to 54.3 per 1,000 sterilization procedures. And it depends on the technique that is used, the age of the patient. Younger patients tend to have a higher contraceptive failure rate. So as you can see here, by the data published in the CREST study, for a partial postpartum salpingectomy, you have a 7.5 failure rate per 1,000, whereas for an interval partial salpingectomy, it is 20. And when you're using a fallop ring, it is 17.7. And a silicone rubber band, it is around 24. So all of these failure methods also should be told to them before they go in for a tubectomy. And as I said, it is a procedure which is much riskier than a male sterilization. So you need to talk to them about the anesthesia. Of course, this procedure, tubal sterilization, can be done under local, regional, or general anesthesia. It depends on the setup in which you're getting a sterilization done and depends on the patient's medical. So this counseling again should be done prior to the procedure itself. And we need to also ascertain that they understand that this procedure does not prevent them from sexually transmitted infections, and they definitely need to use a barrier contraceptive. And reversal procedures are available, but they are costly, difficult to do, and there is no guarantee, and reversal can cause an increased risk of ectopic. So all of this has to be made known to the patient. And there's a plus to this also, that also should be patient. We know that clips, bands, or partial salpingectomy decreases the risk of endometrioid and clear cell ovarian cancers, and a salpingectomy reduces the risk of epithelial ovarian cancers. So traditional tubal ligation will reduce it 13 to 41%, whereas a bilateral salpingectomy reduces the risk by 42 to 78%. This also should be told. So once you have you should take a consent. So when your patient is giving a consent, they should be in a sound state of mind, understand the implications. And if there is a mentally ill client, you get them certified and a legal guardian or a spouse can decide. But you need to understand that the consent of the partner is not required for sterilization, but the partner should definitely be encouraged to come for the counseling. And no woman should be denied a female sterilization based on their HIV status. How do you document this? So once you have taken the consent, you need to take a signature or a thumb impression. And if you are taking a thumb impression, you need to have a witness who is not part of your service, and it should be chosen by the client. And the consent should not be coerced. We have already known in the past about the Indira Gandhi government making sure that a lot of people underwent tubectomy. So we know that it should never be done under coercion and out of free will. So let us look at what is the evaluation that we need to do pre-operatively. All the women should have a detailed history for any medical disorder, any medication history, so that if they are on an anticoagulants, that should be stopped before surgery, and so on. You always pregnancy. So it is always better to do it immediately after a period, if you're doing an interval sterilization, or in the postpartum period when you are assured of no pregnancy. Otherwise, you have to rule out the pregnancy before you go for a sterilization procedure. You do either a pelvic examination or an ultrasound, one of this, to ascertain the uterine ability, to look for any ovarian pathology, and always to rule out cervical and vaginal infections. Cervical cancer screening should be up to date for that women. You need to assess a general medical condition, the heart, lungs, breast, and abdominal examination. A pre-anesthetic checkup should be done so that the type of anesthesia can be decided upon. The basic investigations like a hemoglobin, platelet, urine analysis, a screening should be done. And the patients may have some surgical risk factors which may cause increased problems during the procedure, like a severe obesity, or if they have cardiopulmonary or renal disease, or we are anticipating adhesions, we should communicate the same to the patient. And what are the absolute contraindications? Any infection, you should avoid it, treat it, and then get back to it. Any severe chronic medical illnesses where a Trendelenburg position or an abdominal insufflation can cause acute cardiopulmonary decompensation can also be something that we need to look at and treat that, or make sure that patient is stabilized before we go for a sterilization procedure. So, similarly, any lack of informed consent, any intolerability to anesthesia, or if patient is unsure about the permanent sterilization, it is better not to do it because we don't want them to regret it later. So how do you document it? Then if once you decide after all of this that the patient may be unfit for sterilization now, you need to either document that the patient has accepted, or if you are having a denial, you write that there is a caution that we cannot conduct, it should be conducted with extra preparations in a normal routine setting, or write it as a delay, that the procedure should be delayed until the condition is evaluated and conducted, or a special circumstance where you need an experienced surgeon or a staff and a backup team to do the anesthesia, and most appropriate anesthesia regimen should also be taken care of. And while you're doing all of that, you should give them alternate methods of contraception. So we all know that the permanent methods can be happening in both in the female and the male, and in female approach, a laparoscopic approach, or a hysteroscopic approach, which is no longer done in the market. So a tubal sterilization is the intentional occlusion or partial or the fallopian tube to provide permanent contraception in females. And as I said, it can be done anytime during the menstrual cycle. So during the postpartum period, you can do it while you're doing a C-section, along with it, or immediately after vaginal delivery, in the post-abortal period, or in the interval period. So when you look at the interval period, the uterine size is normal and the incision is always given around the fundus. So that is why the incision is at the suprapubic region. And ideally, pregnancy and ideally should be done within first 2 weeks of menstrual cycle to ascertain no pregnancy. In the post-abortal period, again, the uterine size may be a little bigger. So incision is given usually in the suprapubic region, and it can be combined with a first trimester abortion, surgical abortion also. And if it is a second trimester surgical abortion, you can do a mini lap, but you should try and avoid a laparoscopy. If it's a postpartum period, usually the uterus is enlarged. So that is why your fundus is around the umbilicus, and you may need a subumbilical incision on the skin. And this is usually done within the first 7 days. Usually we prefer to do it within the first 24 hours to assess the infant and to make sure that financially and discharge wise also there is no extra stay for the patient and recovery is easier. So who can do this procedure? Anybody who's a gynecologist or a surgeon or even an MBBS who has been trained specially for mini lap or a laparoscopy can perform these surgeries. Whereas for a vasectomy, any MBBS or above who have been trained specifically in can perform these surgeries. So for any surgery, we need a primary surgeon, we need an anesthesiologist or a certified nurse anesthetist. and a surgical technician, a circulating nurse, a preoperative nurse, and a post-anesthesia care unit nurse. So we all should know about the anatomy, the femoral and the ampulla, the isthmus and the cornea and the blood supply and how to go about doing this surgery. We all need to be aware of the anatomy to prevent any complications during the procedure. So the access inside the abdomen can be either through a mini laparotomy or a laparoscopy. Mini laparotomy is easy. Just needs your basic surgical training. We don't need expensive instruments. Expect major complications, and it can be done in the postpartum or the interval period. Whereas the laparoscopy, it's a quick procedure, but I have to say, if somebody is very efficient in making, both of them take almost a similar time. And laparoscopy, the incision is much smaller, and it can be used also for therapeutic and diagnostic purposes. So if you have an ovarian pathology, you can correct it at the similar sitting, and it is less painful. Whereas a mini laparotomy may take a little longer and difficult, especially in obese patients or patients where you have pelvic scarring or adhesions. Your entry into the peritoneal cavity may be a little difficult. The scar is bigger, the pain is more, comparatively higher infection rate. But laparoscopy can have serious complications, and especially patients who have medical disorders, the insufflation may add the risk. And you definitely need a specialized training, not just for yourself, but for your staff. You need an expensive equipment, and it is generally not recommended in the immediate postpartum period. The interval period, you can go for a laparoscopy. So as you can see here, when you do a mini laparotomy, all you need is a Babcock's, a Richardson's retractor, a tissue forceps, a scissors. Maybe you would need a uterine manipulator and some artery forceps to separate the fat so that you can get onto the rectus fascia. And it is always best to elevate it, especially when you're doing it in the postpartum period. Give an incision at the subumbilicus, hold it with alleys from both sides, lift it up nicely, give your incision, and separate your fat using your forceps, artery forceps, and then hold the rectus fascia, give an incision, and then go into the peritoneal cavity. It is always easier to avoid any bowel injury when you do it like that. And whenever you go in, go to the fundus, move on to the sides and pick up your tubes and go on to the technique. So in 2023, a study was published, which I want to bring to the notice of everybody, that it compared an opportunistic salpingectomy to a standard bilateral tubal ligation following a vaginal delivery. And it showed that every 10,000 patients, salpingectomy would result in 25 fewer ovarian cancer cases, 19 fewer ovarian cancer deaths, and 116 fewer unintended pregnancies than a tubal ligation. Obviously, because if you're removing the tube, there is obviously no pregnancy. So when they compared, there was a lot of effectiveness in the procedure for obvious reasons, and there was reduced risk of subsequent surgery. And more importantly, the ovarian cancer risk was reduced 42 to 78%. There is definitely an increased operative time, increased, especially with adhesions. And as I said, there cannot be any reversal possible in such a scenario. But there was no difference in the surgical complication rate, no difference in ovarian reserve, and it could be cost effective when you look at futures and all of that. So this was published in 2017. And when you are looking at mini laparotomy, you can do the partial salpingectomy, which most of us do. I don't do a bilateral salpingectomy, a complete salpingectomy. I'm not sure if any of you are following. I generally do is what I do is modified Pomeroy's technique only. So we tie it at the base, a ligature at the base of the loop, and ligate it, and 3 centimeters tube is removed. We use an absorbable suture here. So over a period of time, they get separated, and that is how the sterilization occurs. When it comes to Parkland method, a 2 centimeter tube is ligated with a non-absorbable suture. Each end is ligated and the intervening tube is taken apart. We also have other techniques that can be done when you're doing a mini laparotomy. That is, you can use an electrocoagulation, which can block the lumen of the tube. We can do a fimbriectomy. Obviously, the failure rate is high when you do that. And Irving technique and Uchida's techniques, both of them are difficult to reverse. because here we are, the proximal end is buried in the uterine wall and distal end in the mesosalpinx. And in Uchida technique, the tube is severed and uterine end is buried within the mesosalpinx. So when you look at the laparoscopic procedures, you can do either a banding, you can cauterize, or you can clip, or you can tie and cut, or you can do a bilateral salpingectomy. So when you're doing a bilateral salpingectomy via laparoscopy, you can transfer the proximal end through the salpinx to the fimbrial end and tubo-ovarian ligament. You can either go medial to lateral or lateral to medial. You have tubal occlusion procedures where the mid-isthmic tubal segment is occluded. If you occlude more proximally, within 2 centimeters from the corner, you risk a fistula formation. Whereas if you do more at the distal end, just like fimbriectomy, your contraceptive failure is higher. So you can use electrosurgery thing, which can be cheaper because you don't need any extra equipment, or you can use titanium fish
hello.
clips or a silicone
Hello,
fallow.
ഒന്നുമില്ല സാറിന് നേരത്തെ വിളിച്ച ഞാൻ IRCP-യിലായിരുന്നു.
Then the
കഴിഞ്ഞിട്ടില്ല ഇപ്പൊ ഞാൻ എന്റെ
Please mute the others, Abhishek.
എന്നാ പിന്നെ വിളിച്ചോ. ജായറിന് ഫ്ലൈറ്റ് ഉണ്ടായിരുന്നു. ഒന്നും കുഴപ്പമുണ്ടായിരുന്നില്ല ഞാൻ പറഞ്ഞത്. ലാൻഡിംഗ് ഒക്കെ സൂപ്പർ ആയിരുന്നു എന്ന് പറഞ്ഞു.
Dr. Shamima, could you please
എനിക്കറിയില്ല.
Dr. Shamima, can you please mute yourself? Yeah, I think she's done it.
So, yeah, as I said, a laparoscopy tubal occlusion techniques, you can either use a clip or a ring. So clips, you use only 1 centimeter of the tube, so reversal is easier. Even a tubal ring or a fallow ring, 2 to 3 centimeter segment is occluded. So reversal is again very successful. You can also do an electrosurgical desiccation. So you can use your bipolar grasping forceps and fulgurate at 3 sides for more than tube. And for band, always make sure that you are avoiding a tubal laceration. So be careful when you're pulling it into the tubal, into the lumen of the instrument. And if you find a very thickened tube or a dilated tube, you may misapply contraceptive failure. So either use a second clip or a different technique. So there is no hard and fast rule that this is how tubectomy or tubal ligation should be done. As long as you get the effect, that is the contraceptive effect, I think you can use whichever you're comfortable with or whichever is available for you. But what is important is that you tell the patient beforehand that this is what you're going to do. So as we know, laparoscopic tubal ligation advantageous, very successful, reversal also. And as I said, complications can be bleeding, or we may need to convert it into laparotomy, which is very, very rare, and delayed complications like an ectopic pregnancy and migration of the clip or the ring. And it can also be done through other approaches, but obviously none of these are practiced routinely. And in fact, the transcervical Assure device has gone out of vogue and it is not available in the market anymore. So looking at the complications, patients can have nausea, vomiting, abdominal discomfort, trauma to the adjacent organs, especially if your entry technique has not been done well. Or if you expect, in case sometimes in a lot of pelvic adhesions where you had previous surgeries, infection can occur if asepsis is not good, bleeding or hemorrhage if you have not taken care of the tube properly. When you are taking, handling of the tube is not proper, then it can suddenly bleed and it bleeds there. So you have to be very careful and gentle while you're handling the tubes. And patients who have medical disorders can have anesthesia complications, more so in the postpartum period, where you have still the physiological changes causing anesthesia risk to the patient. So you have to be very careful. And long term, you can have contraceptive failure, ectopic pregnancies, and sterilization regrets. So let us look at why the contraception fails. So especially immediately is because you've not picked up on a luteal phase pregnancy. So if you have not ruled out your pregnancy before you went for an interval sterilization and you've not done it in the first 2 weeks, you've done it later, you can miss a luteal phase pregnancy. Or as I was saying, if you have not occluded it properly, or sometimes if you have occluded a wrong structure. Post-graduation, in fact, I have witnessed During a cesarean section, in the middle of the night, we had an emergency C-section, tubectomy was done, and next day morning, patient had lot of hemoperitoneum, and we were wondering what happened. Then we opened her up, and then we realized that instead of the it was ligated. So the round leg, so always make it a point to pull out the tube completely, whether you're doing a mini lap or even a cesarean section tubectomy, that you look at the fimbrial and make sure you're ligating the correct organ, and then you take the bites. So that can be a cause for failed sterilization and also complications. And if you have used a defective device, if you have not done a proper positioning of the ring or the clip, or you've not done in proper desiccation, then you can cause, or sometimes, as I said, if you're too proximal, also you can have a tuboperitoneal fistula, which can cause failed sterilization, and spontaneous recanalization also can occur if you have not occluded it properly. So patients always ask us, so will I have issues if I get a tubectomy done in the future? So you can reassure them that when it comes to menstrual function, there'll be a decreased flow, duration, pain, and they may have a little bit of more irregularity than before, but the ovarian reserve is definitely, and the persistent pelvic pain may be increased in women who already have a chronic pain syndrome. Definitely no difference in the sexual function. In fact, it may improve because you're not worried about getting pregnant anymore. And studies have shown that for some reason, there's an increase in the women who seek hysterectomy post-tubectomy. So I'm not sure about why that is so. Definitely, there is no increase in the breast cancer risk. And in fact, there is a decreased ovarian and endometrial cancer risk. So coming to the other part of the talk, that is the male sterilization, we know that it is the most effective mode of male contraception. There is obviously, we do the occlusion or the interruption of vas deferens, and it can be performed by a urologist, general surgeon, or a GP. It is an outpatient procedure, can be easily done under local anesthesia. It is definitely safer, less costly, and shorter recovery than a tubal ligation. And as I was talking earlier, there is a very low acceptance. So I think we have to counsel well and make sure that husbands take it up more, especially in women who are probably at more risk of undergoing a tubal ligation. And you have to tell them that it is not immediately effective, and the confirmation of sterility should be done later, and azoospermia should be achieved. And once, more than 3 months usually, or after 20 ejaculations, usually that happens. So you have to make sure that they understand that, and they are taking care of with an alternate method till that happens. And this procedure can be done either in the conventional method or a no scalpel method. Conventional method, the incisions are given around the scrotum. No scalpel method, directly on the vas deferens. And post-operatively, the pain is much lower than the anticipated pain. Patients usually need a scrotal support only for 48 hours and basic painkiller. They are good to go. And in fact, vasectomy reversal can also be successfully done in 50 to 70%. And once you have performed the sterilization, a sterilization this, where you type of surgery, which part of the cycle you have done, and whether it was a vasectomy, mini lap, or a laparoscopy, and when was it done. And after sterilization, if the patient resumed your last menstrual period, effectively telling that there is no pregnancy after a sterilization. And for male sterilization, you should make sure that the semen analysis report with no sperms is documented. And a duplicate copy should always be kept with you so that, and the patient should acknowledge that they have received it on the duplicate copy. And we all know that in the public sector, there are rewards for sterilization given out, and compensations for any mishaps also. So if there is any failure of operation, the patient can get a reoperation and medical termination of pregnancy, and awarded 30,000 rupees also. And in case of death, a 2 lakh rupees within 7 days. So a consent form duly signed itself is the form of insurance by government insurance agencies. So what I would want you to take home from my talk is that very, very important in this day and era, you need to counsel about the alternatives before they go for a sterilization so that the is decreased, and your consent should not be with coercion. You have to make sure that they are doing it out of free will, and in spite of explaining all alternatives, if they still want to go ahead for a sterilization, even when you not the right choice, you should let them take the choice. And we can doing a bilateral salpingectomy in place of a partial salpingectomy as an opportunistic procedure if the patient agrees, and always have very good training and avoid, and so that the failure rate in the future and patient does not have any morbidity. And very important to document all of this. Thank you so much for a patient here.
Thank you, Niharika, ma'am. And I request the chairpersons for their concluding remarks.
Well said, Dr. Niharika has touched all the important relevant aspects. And as she told, I think I am working in a medical college at Kottayam. So we can see many patients opting for this permanent methods, even at the age of 24, 25, etc. I think we should counsel them about the alternate procedures like long-acting reversible contraceptives, as Bharati madam had told. And also something like this alpingectomy, I think, should be considered for women with strong family history of ovarian cancer. And also the male sterilization should be brought. We should encourage more males to get sterilized because it's as simple as that. Thank you, Niharika madam, for such a wonderful talk.
Thank you. Thank you so much.
Thank you, Rani ma'am, for chairing the session. Raghavendra sir has left for an emergency. He has conveyed his regards. Without much ado, can we move on for the panel discussion now? The panel discussion, the moderators for the panel are Dr. Shobha Gudi madam and Dr. Aruna Suman madam. Madam is actually traveling and she is stuck up in a rural area with very poor network. She's told in case if it is possible, she might join. Our expert for today, Dr. Sampath Kumari madam. Can we have the CV slides, please? Am I audible?
Yeah.
Yeah. Our moderator, Dr. Shobha Gudi madam, is a professor and head of the department at Philomena's Hospital, Bangalore. She has been a postgraduate teacher and examiner and the chairperson of the Family Welfare Committee, Fogsi, 19 to 22, president of the Bangalore OBGYN Society, 18 to 19. She is also the assessor of the Government of India Project Lakshya.
FPAI. The peer reviewer of...
Previous slide, please, Abhishek. The peer reviewer of the Jogi, as well as the president of the Bangalore Welfare Society of 22 to 23. She has many accolades to her credit. We welcome you, ma'am, as a moderator for today's session. Dr. Aruna Suman, madam. The next slide, please. The professor, head of the department and vice principal of Government Medical College, Jagtial, Telangana. She's been the joint secretary of Fogsi in 2021 and the South Zonal coordinator of Fogsi 22 to 23. We welcome you, ma'am, for this panel discussion. And our expert, Dr. Sampath Kumari, madam. She is a professor, head of the department at Sri Muthukumaran Medical College Hospital and Research Institute. She is the vice president of the Fogsi 22, a senate member of the Tamil Nadu Dr. MGR Medical University, the national corresponding editor of Jogi, the founder secretary of the Tamil Nadu Federation of OBGYN Societies. We welcome you, ma'am. We have a array of panelists who are the stalwarts in their own respective fields. Nonetheless, let's start introducing each one of them. Dr. Sarvana Kumar is a professor and head of department at Annapurna Medical College, the vice president of the Salem Tamil Nadu OBGYN Society, the organizing secretary of the Fogsi South Zone Conference with UA 22. He's also the recipient of Fogsi Dheera Award. We welcome you, sir. Our next panelist, Dr. Hemlata Danduradam, is a senior gynecologist with an experience of more than 25 years. Her special interests include infertility and ultrasound. She has been elected as the secretary of Vijayanagar OBGYN Society, and she has undergone a training with hysterolaparoscopy in Bangalore. We welcome you, ma'am. Our next panelist, Dr. Deepa Mukundan, will not be able to join today as she's stuck up in an emergency. She's a national coordinator and executive committee member of the Midlife Committee Fogsi and the master trainer and core committee member of Veera Fogsi. We welcome you, ma'am. Our next panelist, Dr. Kirti Rajan is a consultant and laparoscopic surgeon at the Renai Medicity, Kochi, and she has been invited as a speaker for various conferences. We welcome you, ma'am. Our next panelist is Dr. Shamima, madam. She's a senior consultant at Aster Women's Health, a lead consultant at Aster Center of Fertility, Aster Medicity, Cochin. She's also a laparoscopic and robotic surgeon and an infertility consultant. We welcome you, ma'am. Dr. Suprajna Shetty is an assistant professor at Kasuba Medical College, Mangalore. She's an undergraduate and a postgraduate teacher, and she has special high-risk interest in critical care obstetrics. We welcome you, ma'am. Dr. Lalita is a consultant at Sri Women's Care and Fertility Center, Tumkur. She has been the chairperson of the Breast and Breastfeeding Committee, Kasova. She's also an active participation of the BPNI ICF Counseling Forum and has been a specialist since 2008. And she's also undergone a colposcopy training in 2012 from Sidwa Institute of Oncology. We welcome you, ma'am.
Thank you, ma'am.
Dr. Susan Thomas is a consultant obstetrician and gynecologist at CMAR Women's Hospital, Thrissur. We welcome you, ma'am. Dr. Pratima Prabhu has undergone an FNB training at high-risk pregnancy and fetal medicine unit at the Fernandez Hospital, Hyderabad. She's also certified in telemedicine and clinical medicine from Harvard Medical School, and she's also a certified in OSS repair. She has been a member of various state and national societies of obstetric and medicine, and along with fetal medicine. Her present designation include fetal medicine consultant, assistant professor, Department of OBGYN at Father Muller Medical College, Mangalore. We welcome you, ma'am. Over to you, Shubha, ma'am, for the panel discussion.
Thank you so much. Thanks a lot. And at the outset, let me congratulate Monica and the PAC committee of Fogsi for bringing about this deliberation. Excellent talks by the two speakers, my dear friend Bharti. I'm so sorry I was not able to send you the extra information you needed on injectables, but without that only you have done so wonderfully, Bharti. I'm very happy that you brought in that important contraceptive injectable in its full glory. You know, it's really a very, very, very cost-effective solution for our women. And Niharika, you spoke extremely well on sterilization. It was a very rewarding listening to both of you. And now I have really an army of panelists. So I don't know whether I should throw the floor open and ask you to talk, or I should ask anything. So let me share the screen to begin with, and we'll take it from there. Let me hope that, you know, okay.
I'm ready to listen also, ma'am.
No, I can't talk for that. I don't want people leaving and going.
Wonderful opportunity.
It will be highly interactive. It will be an interactive session. Just a moment, just give me. I opened the wrong file. I'm sorry. Yeah, I'm ready to share now. Just opening the proper PPT. Yeah. So this will be an interactive session. We will not be, it will not be a monologue by me. It will be a very, very clinical discussion so that we can engage the practitioners in their in everyday practice. We should give clear messages about it, and we should enable more prescriptions on contraception, because that is what is lacking in our practice. So I hope that all of you are able to see my screen.
Yeah, we can.
Try to make it full. So this was not necessary. Okay. So what is postpartum family planning? I think we will go with some definitions to make it interesting. So any of the, Lalita, would you like to say what is postpartum family planning?
Yes, ma'am. Within 48 hours and extended within 48 hours after delivery or after abortion, second trimester, or extended can be up to 6 weeks also. So
Okay.
this is
So
called
that is
as
your
postpartum
postpartum
family
period.
planning.
You feel that is period. I'm asking about postpartum family planning. So anybody wants to give an improvisation on that? There is a change in the concept. Dr. Sarvanan, would you like to improvise on that? Because there's a change in the thought process today.
Yeah, actually, we do contraception, actually, sterilization operations, even after for 6 weeks, and we call it as a postpartum sterilization, immediate postpartum sterilization at 6 weeks also. But then after the WHO, when it tells that it can be extended to the first 12 months following the childhood, because it's a very opportune time for the patient to come back to us, and then we will be able to space it properly, because sometimes the patient may not take a contraception immediately. And so when they come for their next visit on the third or the fourth visit, it is better to give them a contraceptive advice anytime, because that will prevent a lot of complication later on in their life.
So today it is there is a lot of clear understanding amongst global authorities. So internationally, it is recommended that though postpartum period, as Dalita clearly said, that it is 6 weeks, but we have extended it to 1 year now, so that any time the woman comes within this year, the foremost thought in our minds must be whether she is protected from an unintended pregnancy. And that should be the opportunity. As Sarvanan said, that is the opportunistic time for us to provide service. So it never stops with the delivery of the woman. It continues for the 1 year. And the need for this is, can anybody identify why such a logic has been used by WHO for low resource in countries? And today, though we are no longer as poor as we used to be, we still want to accept WHO's directive of making 1 year as postpartum. So can anybody build the logic towards that? Why 1 year postpartum?
Because most of our
Shamina.
Yeah, most of our ladies are getting pregnant again within 1 year actually, and they say that now it is evident 27% of the birth occur in 24 months. They think they are not very well aware that during the lactational amenorrhea period they can get pregnant, and they think that withdrawal method, natural method.
Worded. Yeah, I got your point. Can you make it a little so that the audience can immediately catch it? Okay,
Yeah.
this is what she is talking
so
about.
Most of the births, the 27 births of births are occurring within 2 years after birth, and about 34% within 6 months.
You told that already.
Yeah,
and because of this itself,
there's a deficiency of 65% for the spacing methods. So spacing methods, most of the people are not using.
This is the unmet need. There is a gap of service, which is known as the unmet need. Because which mother would want another pregnancy within 1 year? Nobody. But even then, so many of them are not using a method of contraception, not because they don't want to, it's because they don't have information, they don't have guidance, they don't have counseling, they don't have access, and in some cases, very sadly, they're not able to afford it. So our women are not protected. They're not protected. And this becomes especially relevant because today the number of institutional delivery has escalated. Because so many women deliver in institutions. So what justification we have for sending them away after delivery without talking to them about contraception? So that is the unmet need that we are facing, and that is why government has given us 1 year. Yes, please.
This is one of the dangerous window periods during which the woman cannot stand up and say for herself, I don't want any baby for another 2 years. And she still lives in that era where she cannot vote for herself and seek a contraception for herself. And this is a dangerous window to get pregnant.
And madam, one more thing, like
Mostly,
Suman.
almost 50% of the patients who come for medical termination of pregnancy, the single reason why they are telling they need MTP is that the first child is not even 1 year old. Almost 50% of the patients are telling this reason for MTP.
Okay, so I'll do one thing. I will just finish this slide and then I will open the gallery and we'll have some discussion on this immediate postpartum period. So this is post-placental. I mean, this is the timing of postpartum family planning. And all my esteemed panelists can see the time. No, God has given us so many time intervals to implement contraception for our women. Within 10 minutes of birth, within 48 hours of birth, within 6 weeks of birth, and then 6 weeks to 1 year of delivery. And so today, the conventional counseling, as we started with 6 weeks, what Lalita said, now everyone is able to appreciate now that this is going on from 6 weeks to 1 year. So all of you will do this for 1 year from now. So for a minute, I will stop sharing because it is in my interest now and the nation's interest to make this a platform where postpartum family planning is practiced like religion and not just like science. Because see, what is happening today in our country is there are probably the largest number of births for a nation in the entire world. We have anywhere between 26 to 29 million deliveries. And though they keep on saying that the fertility rate has come down below 2.2%, it is okay. It's a good success. I really compliment everyone for having achieved that. But then the number of women who are already there, they have to give birth. And that is why our birth rate is not coming down that greatly. So even minimalistically speaking, 26 million births in a year, it should get converted into 26 million opportunities for providing contraception. Because this is the time when the mother is at her most receptive. Yeah, this is most receptive for contraception. So we must encourage postpartum contraception. And as Sharvanan already said, postpartum IUCD is an option. And you know, when we had our completion workshop for the committee, Dr. Leslie Regan had spoken in the workshop, and she very rightly said that when a woman is leaving the hospital with the baby in her arms, she should be protected from an unwanted pregnancy. She can have a device in her uterus, or she can have an implant in the arm under the skin, or she can have the progesterone-only pills in her purse. She can even have the hormone-free pill in our country. We always have Chaya. Chaya also can be started after a few weeks of birth. There is no contraindication. Centroman. So POPs can be started after 3 weeks. The progesterone-only pills and Chaya also can be given to her. Implant can be given, IUCD can be given, and merely 6 weeks down the line, she is also eligible for injectables. So that is the strong message I wanted to give, that all women who deliver must be informed about this particular intervention along with the other elements of postpartum care in a very strong manner. So anybody wants to share anything, please tell. Meanwhile, I'll share the screen again. Anyone
No, actually, as Madam told, as the patient leaves the hospital with a baby in the hand, at least we should counsel them. But by the time she comes at 6 weeks checkup, she may be able to take a decision on a spacing method. So I believe the counseling when the patient leaves the hospital is very important.
So the healthy timing and spacing of pregnancy and the benefits is of utmost importance. So I'm very happy that everyone is concurring on this, and we shall go ahead. Now, why it is important is something very simple, right? Because of so many advantages. It can avert death for the mother. It can avert child mortality. What else? What other benefit are we looking for? Isn't this the maximum possible benefit of any health intervention? Closely spaced pregnancy increased adverse outcome like C, so suboptimal. So suboptimal. The other day we had a woman who came with an abruption and IUD, and she was previous cesarean also, and she was bleeding quite profusely. We could not do anything. We could just open the uterus and take out the dead baby and correct her blood loss. She became all right. And then she asked why this happened. And I asked her the simple question, how old is your previous baby? She said, my previous baby is just 1 year old. And she was still feeding the baby. So she didn't realize she was pregnant till she was 7 months. So this woman could have easily died of the abruption if she was not intervened in time. And this was a totally untimed pregnancy, did not give her any result except for another scar and a lot of morbidity. So the health of the mother also is very compromised when there is because this is often undermined. Nobody understands this. Even healthcare providers make little of it when the woman comes back with an early pregnancy. They just focus on the MTP and they send them away. So that needs to change. We have to tell them closely spaced pregnancy will increase the adverse outcome. So I just wanted to say that though we kind of speak passionately about the nation and the population and the stabilization and the fertility rate, etc., the primary thing is the mother and the child. Okay? And that is why healthy spacing is needed. That is why healthy spacing is needed. So you can well see how the statistics are when there are closely spaced pregnancies. You can see this thing here, less than 18 months. Quite a good number of women are delivering, and the maternal mortality is high whenever even the child mortality. So let us move on. Let us move on. That for a breastfeeding mother, what are the options, and for a non-breastfeeding mother? So in a postpartum contraception, we need to first find out what are the options for her. This can be the display. This is one of the charts when we use. Can any of the panelists now tell me, do you use any tools for contraception counseling? Do you use any tools? Is this
Yes,
a good tool for counseling, this particular chart?
Flip chart also is a very good tool to show them
the method.
and counsel them.
What is the advantage of this particular chart? Of course, I agree with you. Flip chart should be there. Yeah. Can any of you tell me why this is so attractive? Suppose it is a woman in front of you who wants to know about contraception.
They can make a choice of
They can
their
make
own.
a choice.
Correct. It is good for
If at
making
all it
a
is
choice.
put in their OPDs or a videograph is kept in OPDs, so they can keep seeing this, viewing this thing for themselves, which is better, and then make a choice. So in the antenatal period itself, if we start portraying this chart, it'll help them better in making a decision by the end of the pregnancy, what kind of a contraception they would need.
You know, I have made an IEC based on this, and it is a one-page one. It can be takeaway for the mother also as she is leaving, for any woman also when they come to. So that can be circulated. I can share all these IEC material are Fogsi, and I can share the soft copies, and you can, make prints and you can utilize for your OPDs. Maybe I should share them in the WhatsApp group. What do you say, Monica?
Sure,
Okay.
ma'am.
Yeah.
Sure.
So we'll
I
go.
think it is
Welcome.
So
I
ये
think
जो chart है, this can be blown up and it can be placed under your glass top table in your consultation room with the arrow pointing towards you. So the woman sitting in front of you can see the most effective method. She can see the most effective method. She can see copper T, she can see implant, she can see injectable and the hormones, etc. And here also some direction is there how to make the method most effective. So this is a good counseling tool. It will supplement your dialogue, whatever you're sharing with this. Now this also can be downloaded from the WHO website, and you can keep it in your outpatient because this shows the methods for postpartum contraceptive choices. And you can see about sterilization that, as has been spoken, within 48 hours and after 6 weeks, male always and condoms always, and emergency contraception after 4 weeks, and for the woman diaphragm, etc., she can be used after 6 weeks. Like that, the hormones will come in after a few weeks, and of course the COCs will come in after 6 months, like that. So these are good charts, and these are the methods which can have further detailing. right? And this is the WHO MEC criteria. So I just wanted the panelists to tell me what is their experience of using these wheels, these, medical eligibility criteria wheels. Do you often use this, and does it help you to identify a safe method?
Yes, ma'am. Should be used.
Identified before giving them choice for contraception.
Correct. And this is how it looks, the wheel. Can anybody opine on this particular chart, the last chart where there are the last page of the MEC wheel, where there are so many alphabetical points here. And then these alphabets A, B, C, D, they are numbered here, and they are used as asterisks on the wheel here. So can any of you identify these? What are these? So this is the finer nuancing which can be done with the MEC wheel. If one has an experience of using, one will know that if it is saying as an asterisk D, you have to turn the page and read the D here, and you will get it that COCs are contraindicated, immediate postpartum, up to 3 weeks, they should not be given because of the risk of thrombosis. So that last part of the information that it is given here in the alphabet D. So that is how the MEC wheel can give so many details. It can give about methods. I think the previous slide shows the information that it offers about 2,000 recommendations for about 25 methods. The MEC criteria, not the wheel, the MEC criteria, and it is developed through consensus of so many systematic reviews. That means it is research based, and then you have the MEC criteria and you have the MEC wheel. Okay, so one question I wanted to ask all of you is whether in the postpartum mother, if she says she doesn't want any method, but she is regularly breastfeeding the child, then are you happy to leave her like that? Because all of us have seen women coming with the amenorrhea of pregnancy overlapping with lactation.
Yes, ma'am. It is a good method if all the criteria are met, and it gives as much protection as a barrier method. If these criteria are met, if there is a breakthrough bleeding, then she has to resort to another method, reliable method, immediately. That knowledge she should have. So,
what is the Bellagio criteria? Anybody wants to tell?
But I see many patients who come with pregnancy when they are breastfeeding, whether they breastfeed exclusively or not. But that is effective for maybe 10 to 14 weeks to the maximum of up to 3 months. So afterwards, probably it will not help them very effectively.
Yeah.
If there is, Pratima.
Good evening, ma'am. So, especially if she's only lactating, exclusive breastfeeding, there should be no formula feeding or combined kind of feeding, and she should not have attained her menstruation. So, these are the two important things.
And she should be within 6 months of birth.
Yes, first 6 months.
After that, it does not protect.
Yes.
So
and there should not be any gap of 8 hours altogether. And there should be no other feeds, and she should feed that baby only, no other baby, and the baby should take the feeds only, not even water additionally. So if all these criteria is met, 6 months till no amenorrhea is a good method, till the baby takes other.
Yeah, it appears that research points in that direction, that it is highly effective if these criteria are met. But where it goes wrong is sometimes ovulation will happen when they stop for a few hours. As you said, it is not maintained. If suppose the mother falls sick due to some reason, and she forgets to feed, or she travels and she doesn't feed, or if the baby falls sick, and doesn't take feed for some time, all this happens, and then she ovulates, but before she can bleed, she would have conceived.
Yeah.
And that is
ovulation
where we see that.
Menstruation.
Correct. So ovulation resulting in pregnancy before menstruation can happen. So this is something that we have to guard against. And I think we must have in our women some post, like we call them after 6 weeks, okay, but we should again call them for a scheduled 3-month visit. As Dr. Sharvanan is also telling, 14 to 16 weeks later, if she comes, we can evaluate whether sex has resumed or whether exclusive breastfeeding is going on. If any difficulty, we should caution her and start her on one of the methods that we have discussed so far. I think all the panelists are agreeing on this, right?
Yes.
Anything
Yes,
else
ma'am.
to add for a breastfeeding mother? Then we can go ahead with some of the method exclusive case scenarios. Okay. Okay. Anything you can add at any time, please feel free. Please feel free. So this was these are some of the charts which you can utilize to tell the, so this is from the government actually, that, if you are just like, all of you are saying that we must give them good education. See, 6 months postpartum, sooner if your menses has risen, but only if you are breastfeeding. If you are only breastfeeding, and if you are partially breastfeeding, then the mother should know that not more than 6 weeks postpartum she is protected from pregnancy. And if she is not breastfeeding at all, sometimes we don't recommend if she is HIV positive, etc. Then after 3 weeks itself, she requires contraception. Okay. So these are the charts for LAM which you can utilize and put it in your case. This is extremely important. It's very important. So please take these charts and put it. Really adds value to your practice and to your clinic and to your hospital. Now, she is a 25-year-old and 11 months back delivered, had 1 period, and after that she has amenorrhea. Okay, but 2 periods and she has amenorrhea of 2 months, and she wants a contraception advice. So she does a UPT. It's not that she doesn't do a UPT, and the urine pregnancy test is negative. Even government gives it. So can you start contraception for her immediately, or do you want to use any other tool to make sure that she is not pregnant? Are you quite okay with the negative pregnancy test? This was my question. Yeah.
No, ma'am.
Then what you want to do?
We want to take history of abstinence or intercourse and any other contraception used.
Correct.
All these things.
So this is a fantastic chart, it is so simple. 6 questions. So in this woman, the which one? The 5th one, the 4th one is applying. She had a baby in the last, period, no? She had a period. So the first one is applying. She has to say, okay, she has to say no to that, right? So she had period only 2 months earlier. So the questions are structured in such a way, this simple pregnancy checklist, that you will be able to identify women in whom you have to do one more test to rule out pregnancy. And those women in whom you can straightforward give off the contraception, because she is coming asking for it. So did you last period 7 days abstain for intercourse since the last period, or abortion or miscarriage? If she has abstained, that is good. Reliable contraception, very good. Baby last 4 weeks, baby less than 6 months but exclusive breastfeeding and amenorrhea, very good. Had a miscarriage in the past 7 days. If she answers no to all of the questions, then pregnancy cannot be ruled out using the checklist. Checklist is of no use if the woman says no to all 6. Then you wait, repeat the pregnancy test, or wait for the bleeding, or induce a withdrawal bleeding. Make sure that she is not pregnant somehow. If the woman says yes to any one, then prescribe the contraceptive. Whichever is her choice, you can prescribe the contraceptive. So this simple clinical exercise will allow you to give the woman a method whenever she comes to you, right? Even if she is not sure whether she is pregnant or not. So the question is combined oral contraceptive safe in a breastfeeding woman? So wanted to know.
No, ma'am.
No, same.
Not ideally not
No,
recommended
never?
until at least. Not at least until 6 months.
Breastfeeding. if she's breastfeeding.
When she's exclusively
the baby is
breastfeeding post that.
But why we can't give? What is the reason?
Risk for
Reduces the breast milk.
Quality of milk also is reduced.
Increases the risk of thrombosis.
Thrombosis risk. But that will be there later also. No?
Quality and quantity.
How
of
we can
milk
give
also.
after 6 months? Before the 6 months it is more?
Venous
The
thromboembolism
quality
risk
of the
more
milk
in
is
the
not
initial first 3
affected
weeks.
according to like.
Please, I'm not getting your name, darling. You're not
Suprajna.
clicking as iPad. Huh?
Okay, Kirti.
Hi, Kirti.
Hi,
Lovely to
ma'am.
see you. Lovely to see you. Tell me what you wanted to tell.
It actually doesn't affect the quality of milk, though we have studied like that. Recent study says that it doesn't affect the quality of milk. It is only the venous thromboembolism risk that is there, and that's why the time frame. So even if it's 3 weeks or 6 weeks that we actually categorize the patient, it is important that we categorize the patient according to the risk of thromboembolism. Like if the patient has some
No, I'm talking
SLE or
about a
anything.
woman in whom the risk of thromboembolism is only related to the pregnancy. That is mild, no? That low risk type.
Yes.
Okay. Then,
Yes.
in a non-breastfeeding woman, you can start as early as 6 weeks.
Yes.
So it is 6 weeks. In breastfeeding women, it is 6 months. So it is mainly because in the first 6 months, if you give exogenous hormones, especially estrogen, there can be some impact on the quantity and quality of milk. But after 6 months, when the breast milk feeding has established extremely well, and the baby is also ready to receive some extra diet, it can be provided. The benefit outweighs the risk. So it is category 2 after 6 months, and it is category 3 and 4 earlier to that, depending on the period. Okay. So you have to identify the medical eligibility criteria, and then you have to decide about the contraception also. So let me just share the same thing again, because you were just taking on the COC. So first 2 to 3 weeks, contraindicated, yes. Throughout 6 months in breastfeeding women, estrogen containing. Not breastfeeding, they may ovulate by 45 days. Therefore, early has to be given. So we can start by 6 weeks. Okay. So let me come to this burning question. How many of you are convinced about postpartum IUCD? Raise your hands. How many are using PP-IUCD? Oh, great, man. Great. Sarvana, intracesarean IUCD.
No, actually,
Intracesarean.
private patients, they don't agree for a PPI.
Intracesarean? Also no.
Medical college.
Thank you, Bharti. Thank you, Bharti.
Medical college I use. Medical college I use, but in private they are very reluctant to use a
Why the
PPI.
dichotomy
You can
of
raise your
care?
hand.
The problem
What
is
do you mean?
Private
Why did
also
you
they
not
accept
raise your
very
hand?
readily. Counseling.
For audience, it is very important. Your followers, your fans who have joined will see you raising the hand. They may also insert PPI.
Yes.
You should raise your hand. So please stand up for PPI-UCD because it's an excellent method. When I was chairperson, we did a study on insertion and follow-up, and believe me, we saw failure rate as low as 3%, 4%, that's all. Expulsion rates were very low actually. So it all depends on the technique, on your training. So please get trained. It is something simple, and you're all people who do laparoscopic surgeries and IVF and whatnot. Can we not put in a PPI-UCD with care? So it is very much possible. And intracesarean PPI-UCD is the need of the day in view of the rising cesarean. At least some harm of the cesarean will come down if you put off an IUCD. Some karmic account, some burden will come down for doing the extra cesarean. I'm trying to say, on a very serious note, let us leave the jokes aside, that this is a good method and it is a scientific method. The problem with us is many of us feel, Dr. Hemlata, I really want you to open the account.
Yes,
I want you to say whether this is a scientific method or not. What do you think, madam?
This postpartum IUCD, it can be we can motivate the patients during the antenatal period only. And even the husband also should be counseled. And as the anemia rate also reduces, and preterm birth also during the second pregnancy, low birth weight, everything is
Excellent. But about the service itself, you are convinced, no, that it is a scientific method. I only wanted you to say that because many doctors feel that it is a crude method, it is unscientific, and it should not be done. So I just wanted to give a clear message that it is evidence-based and extremely scientific method. There is no reason that we should not, there are hardly any negative MEC criteria for this. So it has an answer to so many problems. Only category 4 are only few where there is infection, when there is distortion of uterine cavity. These are the category 4 for IUCD, and none of these conditions will exist in the postpartum mother. And then category 3 also, these conditions will not. In florid AIDS, we will not give PPIUC, but in just HIV positive also we can give. Okay. Then the MEC are less specific for the postpartum IUCD. So we have already said, so whenever there is a septic abortion or puerperal sepsis or unresolved PPH, then don't give. If there has been PROM, don't give. If there is 48 hours and 4 weeks, don't give within 48 and 4 weeks. Category 2, no conditions are identified. That means barring these situations, almost everything else is category 1, and it is within 48 hours and after 4 weeks. Between 48 hours and 4 weeks, please do not insert PPIUCD. And this is a beautiful checklist which is available, and you can download it and you can use it. Then we come to another method, which is progesterone only pill. So what do you feel about this method in a postpartum woman?
Yes, ma'am. Good, ma'am.
Anything good to say about this?
It's actually
Doesn't
safe to
alter
tell to the
the
patient.
Special about the
milk
method.
Yeah.
doesn't alter the breast milk quantity quality.
Excellent point. Very good. All progesterone only methods are excellent choices for breastfeeding mothers. Yes, I agree.
Even
anything else, it's very
And patients
versatile.
actually depends on these tablets, because when we say that it's safe, they feel safe to take
Very
it.
versatile and it is safe. Very versatile and it is safe.
Most
And
of the high
wherever
risk,
estrogen, yeah,
in most of the high risk cases also progesterone only pills are very safe.
Yes.
so wherever estrogen is contraindicated, like hypertension, eclampsia,
Right.
diabetics on
Thrombosis.
insulin, uncontrolled diabetics, all of them. This is extremely beneficial. Okay, so quickly we shall go on. They are available today. The Cerazette is the desogestrel, and there is one more drospirenone containing. Of course, mechanism of action and all, it is very redundant to talk about all that in a webinar. All of you know everything about it. There's no need to tell the theory part. I just wanted to bring out the fact that this drospirenone only pill is now there, 4 milligram drospirenone. It can be given to, it's very versatile. So I said it can be given even in smokers, you know, and it can be given in anemia, any age, older age also. And the missed pill interval is much longer, So it contains 24 active pills and 4 days pill interval regime will be there. And you can take the first tablet, first day of period, and then, you know, the missed pill interval, I just wanted to show that missed pill, this is the one with the missed pill interval. So conventional POP, no, if you have, if the woman has missed her pill and remembers it within 12 hours, then she can continue. But in drospirenone, like the COC, the pill interval is 1 day. So that is another, you know, thing. Can anybody tell me what is this?
MEC chart.
Yes. What is the difference between the blue one and this one? So my son is telling from the other room, one is blue and one is green. But there is more difference.
That's a wonderful answer, Shobha.
Yeah, that's we all agree, ma'am.
He has given the answer.
That is smart answering by the young children.
Yeah, I know. So what is the difference? Anybody knows? Those in the public sector.
This is for India and that is for world.
Which method is extra? This is the extra.
Implants.
Centrochrome.
No. Centrochrome is extra.
Centrochrome.
Remaining everything is there, but implant also was there earlier, but centrochrome is the one which has got added on. So we have our own MEC wheel for the methods which are available in the government sector today, and that includes centrochrome pills. Again, it is very versatile method, almost same as POPs, even better. They say only thing is research on this is less. So with that, we should move on. I just wanted to tell all of you that this. Aparna, call in another 10 minutes, huh? Okay, so then we go on to sterilization. Okay. All of you are aware of this criteria? Anybody wants to talk about this criteria? This is the MEC criteria for sterilization. It has been given by Government of India. This is not there for the rest of the world. Only we have this, I think.
Yes.
It's very good. We just today, we need to heard about sterilization, right? So you should know the MEC criteria. It's ACDS except caution, delay, and special. And I think practitioners should identify which conditions are except caution and delay and special, right? Except is those conditions where you are ready to provide. Caution is, extra precaution. For example, if she is a little,
Cardiac
maybe.
issues. Any medical disorders if the patient is
Yeah,
having.
like that. So correct it and do. Delay is when you want to do it, but you want to wait. For example, anemia or control of hypertension, etc. You do it a little later. But special is where the procedure should be undertaken in a preferably tertiary care when anesthesia and surgical difficulty is anticipated. So like that, ACDS criteria is there. And if you go by this, you will not be denying sterilization for anybody, whoever is asking for it, because sometimes we feel they are too much risky to do it for them. So, but if you follow this, then you will be able to provide them sooner or later. Yeah. Okay. So all of you are familiar with this method. It's a very safe method for postpartum and post-abortal contraceptive implant. So it is there in the market today. It requires minimal training, and Organon is ready to provide the training. It costs around 3,000 for the woman and some in the private sector, and maybe some extra cost for insertion, which the facility can do. So anybody has any experience on implant?
No.
Not yet?
We would like to have some training programs.
Yes,
Yeah.
ma'am.
We can
Should
do
have it in
Bharti.
big
I'll tell
quantities.
Organon, and we'll do in batches of 8 people. I think then they can start insertions, and we'll do
Fine.
that. That will be great. So all of you can kind of
Thank
come
you.
forward to get trained,
ma'am.
and then start insertions, because the Organon people on the field, they are able to provide the device to your hospital also. But you must be able to counsel women for this. So that will also happen. It's very easy to insert actually. It's not a big deal at all. So implant is a LARC method, and it is extremely useful because it has hardly any contraindications. A little drug interaction and all are similar to COCs, but where did my slide go? My screen is seen, is it?
Yes, ma'am.
Yeah, now that.
Yeah. Now it is there. No? Okay. So this is where it is inserted on the inside of the arm, just underneath the skin. And there's more advantages also, because it improves the dysmenorrhea condition and the PMS, etc., and pain of endometriosis, etc. It's quite useful. Do you feel that men are involved enough in family planning in our country, or you feel they can improvise?
No, ma'am, they can improvise. There's not much.
In what ways, Hemlata? In what ways? Pratima and Hemlata should answer this question.
Yes, madam.
What are the ways in which men can participate in family
All
planning?
major decisions are made by Indian men. So he needs to give consent for the woman to adopt the contraceptive.
He should be very supportive of her choice, right?
Yes, and whenever we do counseling, we should make sure that she has brought her partner along.
Yeah, and the mother-in-law also, and the neighbor woman also, who will dissuade her, whatever. But yes, you're right. She should at least bring the husband.
Even Asha workers also should be motivated, ma'am.
To involve men. You are very right, Hemlata. So it is an excellent answer according to me, because when we ask, younger consultants and postgraduates how men can contribute, they will say only vasectomy, because that is one of the ways. But yes, men can have a supportive role, create an environment, and I think we are also responsible for bringing them into the family planning programs, because after all, each one of us, when we come across infertility patients, we say it's a couple problem. So next time you come with your husband, don't come alone. We cannot discuss any intervention unless your husband comes, gets his semen done, etc. But when it comes to contraception, we are not saying the same thing, right? So we must say the same thing. We should ask more participation by the husband. Okay, so next few slides are about, what are the newer pills which are available, like 24/4. Injectables, Bharti has spoken, let us not go into it, right? Subcutaneous variety is there, MEC criteria. Actually, these were the slides I wanted to give to Bharti. I'm so sorry, Bharti. Very bad of me.
It's okay. It's okay.
Then comes the emergency contraception. And I think all of you also feel that, emergency contraception should be offered to women, just to tell them that availability is there and you can use, and then go on to the more regular contraceptive methods. I think we shall speak a few words on the post-abortal, and then we'll wind it up, because we have been discussing for quite a long time and we should not take more time. These case scenarios can wait for another session. I will just go on to the post-abortion. It's better. One or two slides, that's all. Yeah. So post-abortion family planning choices. All of you are aware that fertility returns very, very early, right? And if I say that within 10 days of first trimester and within 15 days, within 4 weeks of second trimester pregnancy, very early. So that means concomitant contraception is necessary, because if we don't do this, the whole cycle will repeat of unintended pregnancy. I think all the panelists are agreeing to this. This is an update on PAFP, and so many deaths will be averted if we give them proper contraception. Unsafe abortion can cause deaths of mothers. We all know that. This is a repeat, sorry. This is a repeat. Okay. So if I ask about counseling guidelines, anybody wants to give any input about counseling for contraception?
She should be opted for the choices available, and she has rights to choose her own method of contraception.
And we should explain, it should be like we are offering her everything on a plate. So we should tell all the advantages, disadvantages, and give her an equal opportunity to take what she wants.
Yeah, without any coercion, giving her choice and giving her freedom to choose, and not directing her towards any particular method.
Yes, ma'am.
Giving her an expanded basket of choice. This is the same chart.
Preferably even keep a person to counsel them during the antenatal period.
Correct. Yes.
An expert.
Having a trained counselor will also help. So in particular, following abortion, it has been seen that LARC methods, when they are offered, they will result in fewer requests for abortion later on. Okay, but the preference for LARC is less. So my message today is, let there be higher preference for LARC following abortion, so that women come back less often. Okay, so these are more information about first and second trimester. So let me just focus on the post-abortal IUCD program. which the government has propagated through their CAC program, and tell you that post-abortal IUCD is very much possible. So I just wanted to know from all of you whether if second trimester abortion happens, then are you ready to provide her with an IUCD? Second trimester abortion. Do you feel
Yes,
that
ma'am,
it is okay?
It's okay. Benefit outweighs the risk, so it's okay
What
to provide.
risk are we talking about?
No
Chances of
sepsis, no bleeding.
perforation or expulsion because of the size of the uterus increases, so benefit outweighs the risk.
Yeah, but the same thing you're doing in this thing also, no? Postpartum also, no?
So injectable contraceptive can be given as a choice method, but
Can be good. No, let us first finish the IUCD. We'll definitely go to the injectable.
Based on the cause of abortion, ma'am, if it's a sepsis or a long-standing IUD and all those things, preferably not to use. But otherwise, in most of the cases, post-abortal IUCD can be inserted.
Yeah.
No, it is
Both
one of
in
the
first
safer.
trimester and second trimester. If you do surgical, you can put it off. If you do medical, you can call them. Right? You can call them first post-abortion, the first follow-up visit in first trimester. Can we not give them IUCD? If they choose the IUCD, we can give.
Can be given, ma'am.
What do you rule out before giving?
Get a scan done to rule out any retained.
Gestational trophoblastic.
RPOC, then?
To look for any
Any gestational trophoblastic
trauma,
diseases or anything?
injury, trauma, yes. The third thing
Trophoblastic
is
diseases?
Infection.
or yeah, presence of infection. So rule out RPOC, rule out infection, and rule out trauma. That will include the perforation, right? So these three things, if they can be safely ruled out, you can provide the IUCD method because it is very good. She will not come back for a repeat request. It can be given after first trimester also. Second, the only thing is the provider eligibility criteria in the public sector is limited for second trimester PAIUCD. Only doctors can insert. Whether after first trimester abortion, even the trained ANM or nurses can introduce.
Yes.
Nurses can introduce. So this is the detail of PAIUCD, which is used in the government sector. Okay. So we can now go on to the methods which are there for the first and second trimester in brief, because we may not have time for all this. That is from the training program. So timing of initiation of PSC. We'll end with this timing of initiation of post-abortal family planning method after the first trimester abortion. If it has been suction evacuation or a spontaneous abortion or suction evacuation, then hormonal methods we can give very quickly.
within 7 days.
Within 7 days.
7 days.
Immediately or within 7 days.
Yeah, because you have used the vacuum aspiration. Of course, it has become less common now to use the vacuum aspiration, MVA. We are all using medical method only, but for the sake of completion, I am discussing it. IUCD, as I said, immediately.
Immediate.
Yeah.
Or within 12 days. And as I said, when infection injury is ruled out. Sterilization, suppose she wants to opt for a limiting method.
Can be done concurrently with the suction evacuation.
Or within 7 days. Okay. Suppose medical abortion. This is what we are doing every day. Na? Mifepristone, misoprostol. So timing of initiation of contraception after abortion. Yeah.
After abortion, around 10 to 14 days after first trimester abortion.
Okay. It can be started early, or you can choose to start on the 15th day of medical abortion after making sure that the abortion is complete. You can start the hormonal pill as early as 15th day. Centroman can be given immediately or can be started as early as 3rd day. Injectable, 3rd day of medical abortion protocol, and IUCD around day 12. So this is giving us the message that concurrent prescriptions are possible. Concurrent prescriptions of the abortifacient along with the contraceptive. And this is happening across the world in high resource, the good resource countries, they are giving off because women are smart and they know how to take, etc. So concurrent prescriptions are possible. Second trimester also, if spontaneously, if she has expelled or some dilatation evacuation has been done, then within 7 days it is possible. IUCD also within 12 days it is possible, and immediately or within 12 days it is possible.
Go to the shop and come in.
Which shop? Okay. So bridging contraception is a concept that if suppose the woman is opting for an IUCD but wants an insertion next month, for some reason she doesn't want to get it done now because some women will feel like the next period comes, then this particular month you have to give a bridging contraception. A barrier or a POP will make a good bridging contraception. Then these are about high risk situations where abortion is provided. It's not about contraception, so I'll skip this. Okay, this is for high risk pregnancies. Okay, I think this is not in our interest today. I'm sorry about the animation. It's not moving. Okay, these are about special situations. I think we are ready to end because this will become too much of discussion. I think I will take some closing comments by all of you. High risk situations, the risk of unwanted pregnancy is always higher. It's better to provide. And so post-abortion family planning is needed for better maternal and child outcomes. Okay. PA-IUCD should be inserted in health facilities at PHC level or above and trained medical doctors for second trimester, PA-IUCD. So I must end with this, that if the woman we treat for post-abortion complications is there because she could not get contraception, we have failed her. But if she leaves without family planning, we have failed her twice. So I think that was a bit strong message only to give, but I could do it only because of the patience of the panelists, and thanks for the opportunity for the PAC committee. I will take some closing comments, especially I'll start with Dr. Sharvana because he has not spoken much. So I'm thinking, let me ask him.
I think it's a very good idea to have the pictorial diagram in our clinic because I feel that we are able to convince our patients better in the medical college than when I talk to them after their delivery at my clinic. So I'll take this as a take-home message.
Very good. But all the methods she should be able to feel that, she should be able to see, because when we see IUCD, they imagine something large being put in. It should show it is only this big, right? Yeah. Thank you. Yeah. Lalita?
Ma'am, my take home is the poem you said in the beginning. We should, along with the baby, we should send her either one contraception on the finger and one contraception in the purse and so on. That's very beautiful, ma'am. Nice to, very artistic, very poetic. I think you should send it in the group.
Yeah, Dr. Leslie Reagan said it and I was very impressed. So I keep quoting
very
it.
Nice.
This goes home to the mind, no? It should go home to the mind.
Yeah.
Yeah. Thank you. Yeah. Hemlata?
EP-IUCD should be made popular in private sector. That will reduce the number of unintended pregnancies and also mortality.
Thank you. Thank you for your commitment, Hemlata. That is wonderful. Susan?
Madam, I think the counseling part is very important. We should start from antenatally itself, at least during the 3rd trimester, we have to counsel properly that they can take a decision by the time of delivery.
Wonderful. Yeah. One thing I must tell you, Susan, though I appreciate a young obstetrician's mind going towards counseling so beautifully. Thank you. It really, I really feel very, very excited to see young minds doing right to clinical practice. I feel very proud of you. But one thing is, whatever this kind of intervention you want to do, you do it in the 2nd trimester. I call the 2nd trimester the happy time of pregnancy. They're more receptive to this extra information. 3rd trimester, the tension of delivery will start, some BP will start, something will start, 2nd trimester is the happy time. So you talk to them about all this in the 2nd trimester. So they are more receptive because just then, they would have finished with the nausea, vomiting, they start enjoying their food, they start planning for the baby shower, they're happy with the anomaly scan, etc. So that is the time you tell them that, look here, everything is going very well, but what about planning? So I think practicing obstetrics is an art, not only in the labor room, but also in the outpatient. That is what I feel. So then, next, please. Yeah.
In high-risk pregnancies, ma'am. So we may be worried about which contraception to use. Now we have the MEC charts and wheels on our fingertips, so it is made our life and job very easy. So we can all have those charts and just easily tell them what is the best for them.
They're so frightened of the side effects, my God. Yeah. Suprajna, beautiful name, Suprajna.
Thank you, ma'am. Like you rightly said, post-abortion, we should not give them a method of contraception before they have, or post-delivery also, before they come up with another pregnancy in the lactational amenorrhea period. It's better to give them a choice which they themselves can choose in the antenatal period, and then stick on to it in the postnatal period as to which they want.
It's them thinking. I think it's important to make them think about it. To plant the seed in their mind. Think about it. Yes. Think about what you want to do. Don't say you will manage without, because you will not, the family won't lose anything. You will be the one to lose, because everybody feels complacent about safe abortion service and they feel it's okay, what is there. But then abortion always has an impact on the mother, always has a long-lasting impact. Someday it will come back to haunt her. And nobody has really researched what women feel after abortion. Nobody has gone into the emotional part of losing that child, okay? So let us not kind of underestimate that, and let us prevent that. Of course, we must be very skilled in providing abortion, but let us prevent that. Yeah. So the last one. I'm waiting for you, iPad.
Kirti.
Kirti. I feel that even if we counsel the patient, what I have understood is, even if we give them all the options, they'll hear all of it, and they'll smile and nod their head. They'll come back without.
They will use withdrawal method. That's what they will say.
Yeah, and they won't come back with a feedback. So I feel that
so what you will do? What you will do? You tell me. This problem is there, universal. I want to know from you what you do, how smart you are in providing the service.
Like
without
said,
seeming to provide the service.
Might be like in second trimester, I would counsel the patient, and the next time she comes to me, I'll ask her, what have you opted for?
She has already refused the postpartum basket of choice, is what you're telling me. So now what do you do?
No, that's it. If she actually says that...
No, we are trying to be very on ground here, no? Realistic.
The problem is, postpartum, when we say all that, she will nod her head and say all these things. So then I would actually give her all the, the patients that have come with low birth weight and abruption and all such issues, and scare her a little bit, might be not
little
too
bit
much
you
that
tell
she doesn't
about
come.
the risk of unwanted pregnancy, abortion,
yes, but when I counsel the patient,
but about the method,
it wouldn't be
that
the patient
won't help
alone.
you in making her choose a method. Yeah.
But I wouldn't counsel her alone. I would make sure that her husband is there, but husband alone won't be enough, because husband will tell her nothing will happen. The doctor just scared you.
Because, I often make the PGs document also. Counseling for contraception done. Because we have had patients who came back with ectopic pregnancy in hypovolemic shock after 3 months. Tell me about it. If it's an intrauterine, it is fine. What if they have an ectopic because they didn't use a contraceptive, right? So you are very right there, Kirti, that you must tell them about the benefits of spacing. But that doesn't give us a solution. So we should look for solutions. The solution is in telling them to use barriers, because you can't right away the condom as it's something which fails. Most often it succeeds only. With perfect use, it is actually giving very good prevention of pregnancy and infection. One thing. Second thing, you can ask her to combine it with lactational amenorrhea. You should say you can use 2 or 3 methods like that. If she starts her period early, you can tell her about the safe period. Like that, you tell her the natural methods of contraception, because they also are effective. They are not, in fact, earlier, that was the only thing which was being used. So natural methods of contraception, barrier protection, even that stupid coitus interruptus, because I don't know why women will opt for it. Honestly, I never understood that. And then finally, the natural methods, and as I said, the LAM method and emergency contraception. Tell them that if you can't accept anything else, if the condom breaks, see that you can get emergency contraception in time. So counseling, knowledge, information about everything, documentation will complete the service. Somewhere it will help her to understand what is the reality about unintended pregnancy and how easy it is to become pregnant, right? So on that note, we should tell Monica thank you, and we should take leave.
Thank you. Thank you, everyone.
Thank you so much, ma'am,
Thank you so
for
much. Thank
this presentation. I am sure all the delegates will have a very, very good take-home messages and at least imply all of these in their day-to-day daily practice. A day well spent, I should say. I thank all the Fogsi office bearers, Dr. Priyankur, Dr. Jaideep sir, Dr. Madhuri Patel madam, Dr. Ajay Mane sir for giving me an opportunity to coordinate such a wonderful event. I would like to thank Dr. Chamila madam and Dr. Subhash who have joined us as guest of honor for gracing the occasion. Our faculties, Dr. Bharti madam, Dr. Niharika ma'am, and Dr. Shobha ma'am, who have done excellent justice to whatever topic was given to them. I would also like to thank all our chairpersons and all the panelists who have spared their valuable time with us for an academic extravaganza for all the delegates. Thank you, Abhishek, for the technical help and the flawless execution of the webinar. And thank you, Corona Remedies. Good night, everyone. Thank you so much.
Yeah, Monica,
night,
I
everyone.
just wanted to
Thank you, ma'am.
request. I just wanted to request everybody